All right, I think we can go ahead and kick off the meeting. So hello, everyone, and welcome to the next installment of the Behavior Maintenance Workshop on Interventions. My name is Sydney O'Connor, and I'm with the NIH Office of Behavioral and Social Sciences Research. And before we begin today's workshop, I wanted to share a few housekeeping notes for attendees and for presenters. So attendees are muted and will not be able to turn on their videos. Live captions can be turned on by clicking More at the bottom of your screen and then clicking Captions. The webinar is being recorded for internal use only. Although the recording will not be distributed to attendees, the presenter slides will be shared with attendees after the workshop with presenter permissions. Because we have a full schedule, we will not be reading detailed presenter biographies prior to each presentation. However, you can access the detailed speaker photos and bios on the workshop website, and that website is listed here on the screen. A couple of reminders for our presenters specifically. So presenters and panelists are asked to turn on their videos when they're presenting or participating in a moderated discussion, and presenters have been asked to share their own slides today. To stay on schedule, presenters will receive a verbal warning when they're approaching the end of their allotted time. We encourage questions and comments throughout the workshop today. Attendees can submit questions using the Q&A function located at the bottom of the Zoom screen. Questions will be monitored by the moderator and workshop co-chairs and answered by the panelists as time allows. And as a quick note, presenters only should use the chat function if they'd like to pose questions throughout the day. So now I'd like to hand it over to Dr. Deborah Young-Hyman, who will officially welcome everyone to the workshop. Thanks, Deborah.
Thank you, Dr. O'Connor. Good morning, everybody. I'm Deborah Young-Hyman from the Office of Behavioral and Social Sciences at the NIH. On behalf of the Planning Committee, I welcome you to the third workshop, Examining the Science of Behavior Maintenance, part of a series sponsored by the Office of Behavioral and Social Science Research and co-led by the NIH-wide Adherence Network. The first workshop occurred in March of this year and focused on conceptualizing the processes of behavior maintenance. Wednesday's workshop, September 20th, focused on measures and the tools to do so. Today, our workshop will showcase successful approaches to achieving behavior maintenance across behaviors, diseases, and settings, and discuss future directions for behavior maintenance interventions, including real-world considerations. A fourth and final workshop will occur in 2024, TBD, and examine best practices for applications in clinical settings. Next slide, please. Next slide, please. Thank you. Some of you were here on Wednesday, but some may not have been, so I'd like to introduce you to our planning committee. First, our co-chairs, Dr. Ann Peters and Dr. Alex Rothman. Ann is a professor of clinical medicine, Division of Endocrinology, Keck School of Medicine of the University of Southern California. Ann brings the lens of achieving behavior maintenance through application of best practices in clinical settings. Alex, a professor of psychology, Department of Psychology, University of Minnesota, is a theoretical researcher who is focused on the drivers, mechanisms of action, and processes of behavior maintenance. We are very fortunate to have these two thought leaders apply their unique lenses to the issues impacting healthy behavior maintenance. I also want to thank the NIH co-leads, Dr. Mike Stirratt from the National Institutes of Mental Health, who co-leads the NIH-wide Adherence Network, Dr. Maureen Monahan Center of the National Institute of Digestive and Kidney Diseases, and Dr. Sydney O'Connor, a staff in the Office of Behavioral and Social Science Research. They have worked tirelessly to implement these workshops. Biographic and contact information is available for the co-chairs, meeting planning committee, and speakers on the workshop website. Dr. Stirratt will now present key concepts emerging from Wednesday's workshop on measurement. Hand the mic to you, Mike.
Deborah, thank you so much. It's a great pleasure to be a part of this meeting series, and the NIH Adherence Network is so glad to partner with OBSSR on it. It's my pleasure now to give you a few takeaways from the Wednesday workshop that we held, which was on the issue of measurement in behavioral maintenance. And many of you may have been present for that seminar. Whether you were there or not, we're glad to offer you this short review of ideas that emerged from that meeting. If we had to pick a single word to represent our Wednesday seminar on measurement of behavioral maintenance, we would pick the word dynamic. And dynamic is a word that was prominent in that seminar. It was prominent in both our spring 2023 seminar on the conceptualization of behavioral maintenance. It was also prominent in our Wednesday meeting on measurement. And this is because the process of adopting and maintaining behaviors has been considered to be highly dynamic and variable as people move in and out of the practice of particular health behaviors. Dynamic also represents the field of research in behavioral maintenance. On Wednesday, we had more than 250 attendees with us, and so it's clear that behavioral maintenance is an area of research that has high interest. Let me just drive quickly through a few additional themes from our Wednesday meeting. First, standards for behavioral maintenance are variable or even lacking across different health domains. We heard that there are questions about what the threshold should be for achieving behavioral maintenance, or what period of observation should be used, and the degree of consistency of behavior that we should expect. These issues are also complicated by the diversity of health behaviors that we study, whether the behaviors are expected to be continuous and daily, or whether they're expected to be variable and only performed as needed. Also, there's the practice of abstinence or reducing certain behaviors, like smoking tobacco or using alcohol or other drugs. So there's a lot of variation across health domains. An additional theme that we heard was about the complementarity of self-report and objective measures. Certain psychological factors, psychosocial factors, really have to be assessed by self-report, but there's great value in implementing passive objective measures when these can be affected, using tools like accelerometers or digital medication monitors to reduce missingness and improve validity of measurement. Third, there's attention to the value of incorporating measurement of psychosocial processes and contextual factors alongside the measurement of behaviors themselves. Psychosocial processes and contextual factors can be powerful determinants of behavioral maintenance, and monitoring those factors might help us to better know when someone is at risk for losing a state of behavioral maintenance. Fourth, we discussed the advantages of technologies for assessing dynamic processes and patterns of behavior. Passive digital monitoring of behaviors like activity levels or medication taking can create incredibly rich data that's very valuable for monitoring and intervention. And then we also heard about how combination of measures can produce very accurate predictive models. Bonnie Spring presented fascinating data related to weight loss, which found that combining data from Wi-Fi weight scales along with other measures through analytic innovations from artificial intelligence can identify important dynamic short-term person factors, like losing at least 1 pound during the first 2 weeks of a weight loss program, that are very highly predictive of longer-term success. And finally, a theme from our Wednesday meeting, which relates to our meeting today, is how active monitoring of behaviors can be very much closely braided with the delivery of effective interventions. And what we heard was how monitoring can be used to trigger and develop and direct interventions to those who will need them. We also heard how monitoring can actually be an intervention by providing feedback to individuals on their behavior. And we also heard how monitoring behavior can help us to program interventions, identify patterns, and identify facilitators and barriers to behavior that can help to create individualized interventions that have improved impact. So what we saw on Wednesday was that monitoring behavior and also intervening on behavior, these two things are very closely braided. And this is something that we think we'll hear more about today. So some ideas and more to come. We'll look forward to these continued discussions, and let me pass back to Deborah now. Thank you so much.
Thank you, Mike. On this slide is today's agenda, which will end at 3 p.m. We certainly hope that you can stay with us for the day's presentations. Ann Peters will moderate our first session, What Works? Example interventions that demonstrate efficacy for promoting behavior maintenance within and across behaviors and disease context, and what was used as an indicator of success. We'll take a break from 1 to 1:20 and then return for our second panel of the day, a moderated discussion of commonalities and distinctions in these approaches and implications for future interventions, moderated by Dr. Pascal Sheeran. At the end of that discussion, Dr. Sheeran and panel will address comments, and questions from attendees. Please be reminded that comments and questions can be entered into the Q&A at any time. Comments and questions may or may not be addressed, but please know that they are being collected and will be used to inform our aggregation of our learnings and our final program. At this point, I'd like to turn the podium over to Ann Peters.
Thank you, Deborah. And first, I want to thank the team that I've been working with. You guys are all amazing. So thank you, Alex, Deborah, Mike, Sydney, and Maureen. As a clinician, I've learned so much about what I don't know, but a lot of the things that we talk about are the things that I do without knowing why. So I was asked to talk about what I do, and I work in two different settings. I work in well-served west side of Los Angeles in Beverly Hills, and I work in under-resourced East LA. And I decided today that I was going to focus on East LA because that's an area of town where, for very many complicated reasons, including complex social determinants of health, it is hard to help people create behavior change. And I want to show how we've been successful. So first, you're going to see Antarctica, which hopefully you see, but I'm not sure you do. Do you see Antarctica?
We do, yes.
Perfect. And then you're going to see my screen. And you see that, right?
Looks great.
Okay, so perfect. So I'm going to talk about persistence and behavior change based on what I've done in both East and South Los Angeles. So as a clinician, truly sustained behavior change is the most important goal. I can get anyone to do anything for a month or two, but that doesn't count in a chronic disease like diabetes or with smoking cessation or all the things I want people to do to be healthier. So I need to figure out how both to promote behavior change and then how to sustain it. And the most important thing that I need to know is who and when people are at risk from deviating from their patterns. Meaning, I have patients who come and they're doing really well. Their glucose levels are great, they're sticking to their lifestyle, whatever, but then they fall off the wagon. And I don't have any easy way to track when that happens, so I don't know when I can intervene. And so when that happens, and let's just say I'm doing remote monitoring of CGM and now I can see when that happens, I still don't necessarily have an intervention. I don't know how to get people to return to whatever they've been doing to sustain their behavior maintenance. And oftentimes I just feel like I'm saying the same old things. Well, you need to exercise, you need to eat better, but I'm not actually, I don't know what to do. And I need you all to help me figure out what I can do to help sustain behavior change, because clinically there's not a lot of tools to help me figure out what to do next. But my experience has been different, I think, than for a lot of clinicians, because about 20 years ago, the Keck Foundation came and they decided they wanted to make Los Angeles a healthier city. And they contacted me and Francine Kaufman, who at the time was at Children's Hospital. And they said they wanted to impact rates of obesity and type 2 diabetes in under-resourced people in LA County. And that was our charge. And so what we did was we, from the get-go, started doing what we did through the community. We did community participatory research, and we got the communities to help us figure out what to do. We had our own original grant funding from the Keck Foundation, and then for at least 10 years, we got other funders to help support this initiative. And from the beginning, we started to work on sustainability of whatever changes we were trying to make. So we first wanted to figure out what communities we'd target. And this is a map of LA County, and you can immediately see the dark red areas. Those are the areas that are the poorest. They have the highest rates of diabetes-related mortality, highest rates of obesity, and the shortest life expectancy. So we took two areas that are actually on the north, on the basically top of the red area, both in East LA and in South LA, and we basically started to go to work to understand what we should do to help. So the first thing we did was to define the baseline, because I really believe that I, from the west side of town, can't really begin to understand what it's like to live in East or South LA. And I don't think that I should make any assumptions. So we got 2 years to have all of our basic researchers, community health workers, to go and understand the communities. And this is the area around my clinic and what it looks like. And it does not look like a healthy food environment. And it is something of a food desert. And a number of people were doing geospatial mapping, and they looked at things like the quality of food in grocery stores, fast food restaurants relative to the schools, all sorts of parameters. So we understood the real sort of problems we were facing, what was where. And there were very few places that had high quality food. But what was more impactful to me clinically was this. And this actually changed my practice, because I didn't realize how prevalent food insecurity was in the population that I was trying to treat. And when you deal with food insecurity, it's very hard to focus on lifestyle and doing whatever I'm asking you to do with regards to diabetes, because if you're going to run out of food, you deal with food much differently than, for instance, I deal with food, because I know I don't have issues with food insecurity. So knowing this about my community helped me clinically do a better job. But then we needed to involve the community. And when we first went to the communities, they said, why should we work with you? The researchers come, they meet with us, they say, we've got this great research project, they're here for 2 years, they leave and they take whatever they've done with them, and our communities aren't any better. So I promised that I would stay. And it's why I've never left Los Angeles. I've been there for working in the same area for over 20 years in order to stick to that promise. So we set up these wonderful community advisory boards, and they worked with us to figure out, to tell us what they wanted. And we did all of these interventions eventually, but the first thing we started with in both South and East LA was to help them bring in farmers markets. And I basically take no credit for this, because they were already in the process of bringing in farmers markets. But we were able to give them kind of the boost that they needed to get this to happen. So we went with them. We helped them deal with whatever government agencies they had to, whatever they had to do to organize all of this. And in 2006, one of the proudest moments of my career was to be present at the opening of the South Central Farmers Market, the first farmers market ever in Watts. And then we opened, or helped open, 2 more farmers markets in East LA. So this was great because we helped them. But the way I helped them the most was to focus on sustainability from the start. So we actually gave a grant to something called SELA, which is Sustainable Economic Enterprises of Los Angeles, and had them help the farmers market people work to sustain the markets. And it worked. Both of these markets, the ones in East LA and the one in South LA, in their own way, have persisted for 20 years. These things worked in part because I think from the beginning, this focus on sustainability was present. But we continued to help by doing all of these surveys, because we were able to go out and figure out how these markets were changing food habits. And by doing this, we helped get more funding because we had data. So we sent our researchers out and they did surveys in the farmers markets, and we did all sorts of things. And then we continued to work with them to find out what more they wanted. And what more they wanted was cooking classes and demonstrations. They wanted grocery store tours. So we got grant funding to do all of these things. And this is not that long ago during the pandemic. This is one of the East LA farmers markets. And we've long since not been needed. The farmers markets are running, they're working, they belong to the community. And I'm really proud of the fact that these worked and were sustained. But I am not perfect. And I was involved in another initiative that didn't work. So this is an initiative that was a partnership with another local university that I'm going to call University X. And I think they came to us because they knew we had access to this part of town. But what they wanted to do was to change the built environment in a way. They wanted to do grocery store makeovers, and they wanted to help work with the high school students to get them engaged in helping heal their community. And I love all of this, and I love this idea, but I'll show you what didn't work. So when you went inside those stores that I showed you the fronts of, they looked like this. It was all packaged food, junk food. The junk food was right by the cashier. It was really easy to go in and buy unhealthy food, and harder, if not impossible, to find fresh fruits and vegetables. So after we did our makeover, or they did their makeover, this is what it looked like when you walked into that same store. Suddenly there's all this fresh fruits and vegetables. There's a garden out back. We made the outside look better. Everything was great. This was a true success in terms of how we transformed the physical store and helped them bring in healthier products. But this is what happened. And this is what happened, I think, for many, many reasons. And I wasn't as closely involved with this project, but I think that it made it harder for the store owners, not easier. So the produce went bad, and the store owners said that their families ate in a more healthy way because they had all this produce they had to eat, but it didn't sell that well. And by bits and pieces, the junk food that was now in the back came up to the front. I think these stores were subject to crime because they looked better than the other stores in the neighborhood. And I think that there were some issues between University X and their oversight of all of this. And again, it wasn't, in my mind, as integrated into the community as the farmers markets had been. And I know there was community work that tried to get this to be part of the community, but I'm not so sure that this was their answer. And this has been something that makes me quite sad because it was a lot of energy and a lot of money, but it didn't work. And I think it's a really cautionary tale, is that I don't have the answers. The communities do. So what I believe most of all is that sustained behavior change begins with a choice, whether it's an individual choice or a community-based choice. This is a choice that people have to want. They don't have to want it to happen. I, as a physician and as a researcher, can facilitate that choice. I can help them succeed. I have a certain amount of wisdom. I have grant funding. I can guide and support, but I can't make the original first step. And I really don't want to run what's happening. I want to help people along the way. I think that measurement, that what we do as we measure success, so in my office, I measure time and range and A1C, that measurement can help perpetuate success, but I think that people need to own the measurements. They need to say, I believe in that measurement. It resonates to me. Let's get better, or let's work on that. And I think that's really important and easy in diabetes because people come in and say their time and range or their A1C. But I think in all areas, it's really helpful to have measurements that help with success. And then I also would argue that long-term success can be measured in multiple ways. It's not necessarily the way that I always think of success. And when I ask my patients, why do you think you're doing well, or what's good about this, it's often not my answer. So I think that what we need to do is to look at the entire process and figure out what things work and what things don't work. But it's going to be very specific to the communities we're working in and to the individuals we work in. But I really do believe that as part of this and other initiatives, we can really start focusing on these sustainable behavioral interventions and make a real difference. So with that, I'm going to stop sharing, and we are going to move on to our next speaker, who is Robert Schnoll, who's going to, or Robbie Schnoll, as I learned earlier, to talk about intervention in smoking.
Thanks so much, Anne. That was a really interesting talk. Anne, can you just let me know you hear me?
Yes.
Great. Okay, terrific. Let me bring my slides up. All right. Great. Well, thanks. Good morning. Good afternoon. Thanks very much to the meeting organizers for inviting me to this workshop. It's really my pleasure to share with you an example of the work that we've been doing to try and address tobacco use both in an effective and a sustainable way. And the work that I'm going to share with you focuses on our ability to develop and test what we think are sustainable implementation strategies to improve the use of treatments for tobacco use in the context of cancer care. So let me just share with you some sort of broad brushstrokes of what sort of drives the work in our lab. We're really focused on trying to understand ways to reduce the overall rate of tobacco use in the United States. Over the last 50, 60 years, one of the most monumental achievements in public health, shown in the top right, is the substantial decrease in the rate of tobacco use among adults in the U.S. From about 50% back in the 1960s to about 18, 17% in 2014. But over the last decade or so, the rate of decline in U.S. adult smoking has really plateaued. It sits around 14% now. So we really need to understand how to reignite the kinds of progress that we made over the last 50 years in bringing down rates of tobacco use continuously. So our work has focused on at least two factors that we think are potentially driving the plateauing of tobacco use rates in the U.S. The first one is shown on the table on the right, where you see the estimated quit rates from a range of FDA-approved medications or combinations of medications for tobacco use. And what I've highlighted in red is the main message, and that is that the best case scenario for treating individuals who are interested in quitting smoking is that we can get about a third of them to quit smoking. And whenever we're talking about quitting smoking, we're typically talking about the ability to quit smoking over about 6 months with self-report and a biochemical verification. So best case scenario is about a third of smokers who are interested in serious about quitting are able to quit successfully, leaving, as you can deduce, 2/3 of the population of folks who try to quit smoking unsuccessful. So we really need more work to invest in the development of more effective treatments. But the second area, the second factor that underlies the sort of stalled progress in bringing down tobacco use rates in the U.S. is shown on the left, and that's what I really want to focus on in this presentation. And that is that most smokers who are trying to quit, unfortunately, don't use evidence-based interventions. And what I mean by evidence-based interventions are FDA-approved medications and guideline-based behavioral interventions, like most typically cognitive behavioral therapy and counseling. And what I've highlighted in this chart is that if you look in the blue circles, somewhere between 5% or a third of individuals who are trying to quit smoking are using these evidence-based interventions, and that's actually lower than folks who are using cold turkey, shown on the right, or using NVP, which is a novel tobacco product like e-cigarettes, which currently are not evidence-based and approved by the FDA. So in this presentation, I really want to focus on the work that we're engaged in to address this practice gap, this really gap between the availability of evidence-based interventions and the failure to utilize, for the most part, these evidence-based interventions or provide these evidence-based interventions from clinicians. So the question that we've been trying to focus on over the last number of years is, can we use implementation science and behavioral economics as a model for sustainably increasing the use of tobacco treatments? And I'm going to show you a case example of how we've tried to approach this question. So just to get back up a little bit, to give everyone a sort of level understanding of how at least we're thinking about implementation science and then behavioral economics, the focus for us is on, in implementation science is practice gaps, meaning this gap between what we know works on the one hand and what clinicians provide or patients use on the other hand. And we think tobacco use is a really prime example of a practice gap for which implementation science can be really helpful for trying to address. So it's well known that it can often take almost 2 decades for effective treatments to get into clinic. So that's the sort of underlying context of that promotes these practice gaps. But across many areas, evidence-based treatments that are well established are still dramatically underutilized. And the focus of implementation science research is to identify multiple level barriers and facilitators. For us, this is patient level barriers or facilitators, clinician level barriers or facilitators, or system level barriers or facilitators that can prevent or promote the use of evidence-based interventions. In our context here, it's about tobacco use treatment. And consistent with our approach to scientific rigor, we rely on certain conceptual models to help approach this question and propose potential solutions for addressing practice gaps. There's lots of different models out there: Consolidated Framework for Implementation Research, the ERIC Taxonomy, and behavioral economics. For us, we've been focused really on using strategies, piecing them together from behavioral economic framework to try and develop implementation strategies that we would test to shrink these practice gaps. So behavioral economics, for those of you who are less familiar with the framework, is rooted in a number of different assumptions. And let me just highlight a few that underlie the work that we do. So, we're all, incredibly busy people. We all live, busy lives, and we're in a very complex world that requires us to make, very quick decisions, often with incomplete information. And as a consequence of living in this kind of complex world where we have to make very quick decisions, we have come to rely on heuristics or mental shortcuts that help us make decisions. But unfortunately, these heuristics or these mental shortcuts to making decisions often are susceptible to particular biases that lead us to making less optimal decisions. And what I mean by less optimal decisions in this context is the failure to use an evidence-based treatment for treating tobacco use, either from a patient perspective or from a clinician perspective. We rely on biases like status quo bias, where we rely on what we just know rather than incorporating additional information, or focusing effect bias, where we rely on a single experience to sort of understand how we're going to make a decision. And then finally, systems are also influential in addressing practice gaps. And behavioral economics recognizes that we need to design systems in a way that makes it easier and facilitates making the best health decisions for us. So our application of behavioral economics uses the concept of a nudge to help facilitate the provision or the use of an evidence-based intervention. And we've been using this concept for a number of years to try and understand how we can move patients into using evidence-based interventions, or make clinicians or encourage clinicians to provide evidence-based interventions. And we've explored a number of different ways to manifest these nudges in clinical decision-making, where we use frame messages directed at clinicians and patients that are designed to target these heuristics and try and overcome these mental shortcuts or biases that lead us to making less optimal decisions. And framing information in a particular way, setting defaults in the electronic health record to sort of nudge individuals towards making the most optimal decision, making 1
minute warning.
Oh boy, sorry. I better move fast. Sorry. So let me quickly move to, well, that's surprising. Sorry. So we've tested this in a 4-arm pragmatic clinical trial where we're testing nudges directed to patients and providers, or both, compared to usual care across a large health system in our cancer center. And we integrated our clinician nudge as a best practice alert, targeting omission bias, and our patient nudge pushed out through our patient portal directed at status quo bias. We had over 2,000 patients that were randomly selected for one of the four arms. We had over 200 clinicians, and they were cluster randomized based on how they worked together. And our outcome was engaging in tobacco treatment. And what we found was that when we compared our groups, we found that the clinician nudge, addressing a particular bias that clinicians had, almost tripled the rate of providing tobacco use treatment compared to usual care. And so this nudge directed at omission bias could be effective and low cost and transferable to situations to improve the use of evidence-based treatments. And we have sustained this clinician nudge in our health system and are seeing over 100 patients a month being targeted by our message and encouraged to use tobacco treatment long after the end of the study. So sorry for rushing. Thank you very much to all my collaborators, and I'll stop there.
Wait, I've got to unmute myself. That was excellent. And I know we rushed you, but I'm sorry. All right, so our next presenter is Bernardine Pinto, who's going to talk about intervention in physical activity.
Thank you, Anne. Can people hear me?
Yes.
Okay, and can you see my screen?
Absolutely.
Okay, great, thank you. Welcome everyone. Greetings from the University of South Carolina. And thank you for the presenters for inviting me to share some data and studies that we've been doing. So most of the work I've done is on physical activity promotion, getting patients with chronic disease, middle-aged and older adults to become active, and then of course the challenge of getting people to stay active. So the focus here is on cancer survivors, who are recommended to exercise for at least 150 minutes. This is a threshold of moderate to vigorous physical activity each week. And these are national recommendations because we have data to show that exercising at that level does improve fitness, quality of life, and reduces fatigue in several cancer survivor groups, who of course face many difficulties as they navigate side effects and long-term effects of cancer. So we've been doing some work, especially with home-based interventions, delivering physical activity counseling to these cancer patients to help them to become active. What I've also been doing is to try to move more in the area of dissemination and implementation to try to get the message out beyond research staff. And I've partnered with community-based organizations to provide peer support for physical activity promotion for cancer survivors. And my partners for several studies were Reach to Recovery volunteers from the American Cancer Society's Reach to Recovery program. These are breast cancer survivors providing emotional support to usually newly diagnosed patients. So we trained and supervised them to deliver a home-based intervention program. And many of you would be familiar with what you're seeing right now. When we deliver the program for 12 weeks, we get nice effects for physical activity promotion. And when the phone calls stop at 24 weeks, the intervention group started ratcheting their physical activity down. So this particular trial that I'm going to share with you today focuses on how are we going to keep that solid bar higher than what we have seen in this trial. How do we keep that activity sustained? So I want to provide the context for this. The literature that we went back to was some review papers on what maintenance is. And we looked at Gelso's definition, where they looked at maintenance as evaluation of a behavioral outcome at least 3 months after the intervention was done. And in their review, they found that some of the studies that were successful in maintenance were associated with certain features of those interventions, that they needed to be at least 6 months long, face-to-face contact, using more intervention strategies, and using follow-up prompts. So we kept some of these ideas in mind while we were designing our intervention trial. We also looked more specifically at interventions focusing on physical activity or diet for breast cancer survivors. And in this particular review done by Spark and others, what they found was, it was very interesting. Successful and non-successful trials actually use the same number of maintenance strategies, such as prompts planning. And only 4 of those trials actually achieved successful maintenance. And here the outcomes were fitness, strength, physical activity, or energy expenditure, and 6 did not. What they recommended was to extend the program contact with participants to help with maintenance, but there were no clear recommendations as to what strategies would be effective. So what we were trying to figure out, okay, what do we do here? We were thinking about what strategies should we focus on in adoption phase versus maintenance, and what should be used across. When do we assess maintenance? We were using the trans-theoretical model that usually defines maintenance as something that you're doing, or at least physical activity, for more than 6 months. But you have to wrestle with that, with the founding period, the time it takes to recruit your participants, and all those challenges that come with intervention trials. But also very importantly, I wanted to be very pragmatic, because we cannot have interventions that cost a lot of money, and especially when you're working with community-based organizations. So usually when you think of maintenance, you're trying to taper whatever intervention strategies you're proposing. So this led to the Moving Forward Together 3 trial funded by NCI. And the goals were to test the effects of 3 programs, maintenance programs, among 150 breast cancer survivors aimed at maintaining physical activity after a 3-month phone-based physical activity program. So it's a 3-arm study design over 12 months. And here's the schematic. So the 3-month intervention is offered to everyone. It's the same intervention. And after that, you have 6 months of 3 different maintenance programs. And the assessments are baseline 3, 6, 9, and then at 12 months. So there is nothing that happens, no intervention between 9 and 12 months. So it's a phone-based intervention for the 3 months, low-key, low-tech, very convenient, and helpful for people who want to talk to somebody versus interacting in print. During the 3-month trial, very briefly, it's 12 physical activity counseling calls. People are expected to monitor their physical activity using a pedometer, a heart rate monitor. You're promoting physical activity at moderate intensity. These are peer supporters, so they can talk about breast cancer, what the treatments are like, what recovery is like. And then we give them some print materials, and we gave them some print feedback at specific intervals. So theoretical constructs for adoption, we're focusing on self-efficacy, and you can see how we try to do that, how we focused on social support. People were encouraged to get support from family and friends, but they also got their support from their coach. We focused on overcoming barriers to exercise, encouraged them to find different activities so they didn't get bored, same routine every day at the same time. And because it was based also on the trans-theoretical approach, we focused on motivational readiness, helping people overcome some of the disadvantages of exercise, because that's what you encounter when you start becoming active. Otherwise, you think exercise will be glorious until you realize you get up in the morning and do everything before you leave the house. So our maintenance programs were what we hoped would be pragmatic, and they were theory-based. So we had 3 maintenance programs. So the first group was Reach Plus. We asked them to monitor the activity. We gave them feedback reports. Evidence-based strategy, we've heard before about the importance of self-monitoring. Reach Plus phone, in addition, received not weekly, but monthly calls from their coaches, theory-based, social cognitive theory, motivational readiness, and relapse prevention. We offered monthly calls because our previous participants had told us they liked the calls, they found them very helpful, but they wanted more extended contact. And also because the literature suggested we need to have longer intervention delivery. So that was our rationale for monthly calls for 6 months. Reach Plus Message, we provided weekly email or text messages for 6 months. Again, theory-based. We selected that particular strategy very pragmatically because community-based organizations like the American Cancer Society use email blasts to contact people. So it's something that we thought would be doable, that we hoped would be relatively inexpensive. So just for you all to understand, if the question arises, or what did you do during the monthly calls versus the weekly calls? I've just shown you here the difference between the phone calls. For those who received monthly phone calls, the focus was on staying active, planning if some unexpected situation will come up. What do you do to get back onto your routine? And getting back onto your routine if you did stop exercising for a few days or a few weeks. I'm just sharing a few of the email messages that we sent participants. Again, these were theory-based, motivational readiness, and
1 minute warning.
Okay. We didn't expect any differences between the groups at 3 months, but we did expect differences in 9 and 12 months. We had very briefly assessments, as I mentioned, 7-day physical activity recall, self-report, as well as accelerometer data. These were our questionnaires on theoretical constructs, self-efficacy, barrier, social support, enjoyment, and motivational readiness. We had 161 participants, so we exceeded our goals, and you can see they were mostly white, early-stage breast cancer patients. I will skip over the analyses, and here are our results. Our Reach Plus message and Reach Plus phone exceeded Reach Plus both at 6 months, 9 months, and 12 months. This is self-reported data. It's consistent with accelerometer data. Very surprisingly, Reach Plus message actually exceeded Reach Plus phone at 9 months. And this is self-reported with physical activity. Threshold, meeting physical activity guidelines at 3 months. The Reach Plus message exceeded Reach Plus phone and Reach Plus. And at 9 months, Reach Plus message and Reach Plus phone exceeded Reach Plus. So some of our hypotheses were supported. We also did tracking of our costs of our program, again, because we wanted to be very pragmatic. And clearly, the weekly text or email messages were cost-effective in terms of physical activity outcomes. So we have several strengths of our studies. I didn't share this with you, but we do know that our intervention was delivered as we expected. But it was largely a white educated sample. And although our effects were stronger for Reach Plus message, we had greater attrition in that group. So text and email messages we found can facilitate physical activity. We do need to map the behavior change techniques because we did not do that. But these are maintenance programs that can be implemented by community-based organizations differing in resources and also differing in technology. We did do some moderator analyses just to see who benefited from what. And I just want to very briefly share that one group profile which captured 44% of our sample. They were married, they were white, higher income, preparation stage of readiness, and higher social support. If they were randomized to Reach Plus, the regular Reach Plus, they did much better than if they were in Reach Plus phone or Reach Plus message, which makes sense because they had a lot of social support, so maybe they didn't need coach calls. I'm going to just show you what happened with the second profile. These were people who did better with Reach Plus message. These were office-based employees, mostly African-American, so probably they could check email and text quite often. So they did better in Reach Plus message. And finally, the only group that actually did better with the phone calls were the women who had stage 1 cancer, were contemplation stage of readiness, but actually had lower social support. So they did better with the monthly phone calls. And I'm going to end there. These are data that we have on mediators. I'm just going to skip to the end. The weekly text and email messages did better. Their effects were through getting social support and increased enjoyment of physical activity. And we were a little surprised at that. The peer mentoring, the coach calls were effective through strengthening self-efficacy, but coaches needed to help participants get social support from other people and also help them to get more enjoyment out of activity. And with that, I am going to end. Thank you for your attention.
Excellent. Thank you for your wonderful talk. And we're now turning to Dr. Joanna Arch, who's going to talk about intervention in medication use.
Wonderful. Thank you. It's a joy to be here. Thank you for hosting. I am just going to start my slideshow here. Can you all see that?
Yes.
Okay, fantastic. So I'm Dr. Joanna Arch from the University of Colorado, and I am here to share with you today some initial work we've actually done in this area, which is relatively new for us. leveraging personal values to increase endocrine therapy adherence among breast cancer survivors. And interestingly, our intervention was also called REACH. So hopefully we can keep them apart. So as I don't need to preach to this crowd, that medication adherence is really one of the largest behavioral problems in all of medicine. And that is certainly true in breast cancer as well. So for the most common form of breast cancer, estrogen receptor positive breast cancer, adherence rates to a daily medication known as adjuvant endocrine therapy, which is prescribed for 5 to 10 years following primary treatment for breast cancer, cuts breast cancer recurrence rates roughly in half. So this is a very powerful medication. However, these benefits are substantially reduced among the half or more women who do not adhere as recommended. And not only are breast cancer recurrence rates higher, but mortality rates are higher as well. There are many risk factors for non-adherence, dozens and dozens, for medication in general and for AET in particular. However, we were interested in the finding that greater negative affective associations and fewer positive affective associations with this medication predicted poorer persistence and poorer adherence over time. And this was the angle that we wanted to try to tackle with an extremely low touch intervention that I'll talk about next. So I'm not going to get into the full theory behind this intervention. I'm going to kind of dive right in today. We also have an intervention that we titled REACH. It's a very popular name, apparently. And this is a brief theory-driven intervention to enhance AET adherence by specifically, it's not allowing me to forward there. We designed an affective cue to action that was based on women's personal values and primary sources of motivation for taking AET medication. So rather than just kind of a boring cue to action, like you might hang to do breast self-exams in your shower, this was an affective cue to action that was really intended to shift the affective association with the medication in a visual kind of way. So what we had women do is we took them through a very brief single session online program. And I'll show you a few snapshots from that, including from here. And we had them contact their primary motivation for wanting to take the medication while also providing lots of tips and validation around side effects, which is one of the primary reasons why women don't take these medications, and very legitimately so. So we acknowledged and validated side effects, gave some tips, and then for managing them, including discussing with their healthcare team. And then we had women contact their primary motivation and design a sticker, an old-fashioned sticker that we mailed to them. We had them design online a sticker that captured their top motivational reason in an image for taking this motivation. And these are examples of what stickers looked like. So at the top, they said, I take these for, and then there was an image of the reason why they personally wanted to take this medication. So we tested this idea out in a recent randomized trial that was funded by the NCI and R21 with 88 breast cancer survivors who were estrogen receptor positive breast cancer survivors who were prescribed this medication for 5 to 10 years each. And we compared our intervention, which combined education about managing side effects with this values intervention versus the education alone in a 2-arm trial. And this study was run entirely remotely. So we have longstanding collaborations with local community-based cancer centers here in Colorado. We recruited online. The study was entirely online, and we mailed them the sticker, and they took a picture of their pill box with the sticker on it and texted or emailed it back to us. So it's very low touch intervention. And any women who reported any kind of even low level difficulty taking AET every day and had been taking it for at least filled a prescription for at least 2 months. So this is really in the behavior maintenance stage that we're intervening, and had at least a year left on their prescription were eligible. So you all asked us to emphasize what our primary outcomes were. And our primary outcome was actually something that's rarely been used, this specific outcome in cancer, which is we used pill boxes that are out of South Africa that have been widely used in HIV, but not so much in cancer. They're called Wise Pill. They're sleek, they're black, they're a little sexier than classic pill boxes. They have no buttons on them. They're extremely easy to use, even for folks who are technology averse, and they can fit in your pocket. They're called Wise Pill, and our primary outcome was the percent of days per month over 6 months that women were adherent to AET following this intervention. And you can see we designed the stickers to stick specifically on the Wise Pill boxes. So this was the start of the REACH Values Plus Education intervention. It was very colorful, everything online, super easy to navigate. And we offered navigational coaching, but fortunately, not a ton of women needed it because it was very easy to follow. So this is an example, what most motivates you to take care of yourself. We asked them to select up to 6 values. These go down a bit further than you see here. And then we had them narrow to their top value for taking care of themselves. And we linked that in various ways to taking their AET medication. We gave examples of how to create the sticker. So let's say Kathy's top values are connecting with her granddaughter and enjoying the outdoors. Remember, we're in Colorado. A lot of people here are outdoors a lot. So click on a value to see how she created her sticker reminder of that value. So we did this for the granddaughter. Most people uploaded images, but some people preferred phrases. And we showed an example of what Kathy did with her value of connecting with her granddaughter around creating her sticker. And then we say at the bottom, some days Kathy doesn't want to keep taking her anti-hormonal medication because it makes her feel tired. When she sees the sticker of her granddaughter on her medication bottle, she remembers that even though she will feel more tired now, she wants to be around to develop a long, meaningful relationship with her granddaughter, which motivates her to take her medication even when she doesn't feel like it. We had them choose the color for the top of the sticker. We showed them various examples that I've already shown you. And we actually, when they uploaded their image, we produced what the sticker would look like for them online. So they would know what they were getting and they could tweak it if they didn't like it. And then we sent it to them in the mail. So you can see here, this was not a home run. This was an extremely low touch, 20-minute or so intervention. But what we found comparing REACH to education is that we found an effect that lasted for about 3 months. So unfortunately, we have a big ceiling effect in this sample. They were not as non-adherent as they said they were per Wise Pill measurement. But what we saw is that in REACH for the first 3 months, there was no decline from baseline in adherence, whereas in education, there was an immediate decline that continued throughout. But then after 3 months in REACH, there was a significant decline from baseline. Now, all these folks are relatively adherent, but they're starting to kind of veer off there at the end. So we saw an effect.
1-minute warning.
But it did not last as long as we would like it to in the future. We also saw that this intervention seemed to capitalize on strengths, and we saw larger differences up to about 17% in adherence initially among women who had more positive attitudes toward the medication at baseline or better relationships with their physician. So I'm gonna, we have a whole qualitative and mixed methods aim that I'm going to skip over, but suffice it to say that most women really enjoyed this intervention. And there were 2 that didn't, and those were women who ultimately had to give up the medication because the side effects were too severe. So in conclusion, visually linking personal values to AET use is a promising approach to boosting adherence in the short term. However, we now need additional strategies to boost endurance and efficacy over time to get past that 3-month mark and to see bigger effects. And we also need additional strategies to increase efficacy among women with poor physician relationships and low positive affect towards AET at baseline, who we identified as being at risk for not benefiting from this intervention. But stay tuned. We are now piloting a related approach in this space that is more in-depth while maintaining a low-touch approach that may better help women who have more negative AET associations and more negative affect or depression at baseline, because we know that a lot of negative affect and depression are major risk factors for medication non-adherence. Thank you.
Excellent. Well, thank you for that wonderful talk. And we're now going to move on to Catherine Ross, who's going to discuss intervention in weight loss maintenance.
Get my slides up. All right, can you see all right?
Yes.
Okay, so it takes over my screen. I can't see what's up. All right.
No.
Hi, everyone. My name is Kat Ross. I'm going to be talking about an intervention for weight loss maintenance. One difference I have over the other presenters is I'm actually talking about a trial that's ongoing. So I don't have results, but I do have some discussion on evidence-based approaches that we have integrated into this intervention. So first off, for context, I am talking about weight loss maintenance in relation to behavioral weight management programs. So not in relation to pharmacotherapy or bariatric surgery. And these interventions remain the first line approach for the treatment of obesity in adults and consistently produce weight losses of about 8 to 10% of initial body weight, which is clinically meaningful. Unfortunately, as our common problem for everyone here, long-term maintenance of this weight loss remains a substantial challenge. So we see this figure a lot in our literature. We call it the check mark, wherein folks initially lose weight and then at the end of treatment, slowly start regaining weight. And we typically characterize this phase after the end of treatment as a maintenance phase in our interventions, even if folks have goals that are continuing to center on weight loss. And I made that figure up on the other slide, but just to show you, here it is across our literature, this check mark. And one more thing I just want to have as background introduction before I get into my intervention is a bit of reflection on the different thresholds we use to define maintenance. And Rena Wing gave a great discussion of this on Wednesday, so I'm just going to briefly go through that various thresholds do exist. We have thresholds of no weight change. Then we have June Stevens, 3% from a designated weight, because our weight tends to go up and down by about 1 to 2% a day based on hydration, salt, physiological reasons. So 3% is more likely to be actual body weight over time. And then we have thresholds that are related to clinical meaningful outcomes. So in relation to risk factors for type 2 diabetes or cardiovascular disease. And while we don't have an established threshold like smoking, I feel like our field is kind of coalescing around this losing 5% and keeping it off for at least a year. That's what I see in a lot of maintenance trials and what I'm going to be using in the trial that I talk about today. So I'm going to be talking about an trial looking at the evaluation of an adaptive intervention for weight loss maintenance. And quickly for the design, everyone in this trial gets an initial gold standard comprehensive weight loss program. So it's 16 weeks. And then people who lose at least 5% of their initial weight are then randomized to the maintenance trial. And this is we're studying weight regain, and we can't really study regain in people who haven't lost weight to start with. And so at that randomization point, they're randomized to one of two conditions. They're both maintenance programs. And for the next couple of slides, I'm going to talk about components that are in both conditions, because those are things that are from our literature that have a lot of evidence support. And that was one of the focuses of this today, was what does the evidence currently say? And then what are we doing next? And so then I'm going to talk a little bit towards the end about this adaptive maintenance program. So the key components that are shared across these maintenance programs is that they're extended care interventions delivered by an interventionist via telephone. And they're focused on promoting long-term adherence to dietary intake and physical activity patterns through behavioral skills, the similar skills that we introduced in the initial programs, such as goal setting, self-monitoring, problem solving, similar to what Bernadette Pinto was talking about earlier, using motivational interviewing, CBT type approaches, and supportive counseling. And I'm going to be talking about these three components today, because as you see, we have 10 minutes and it's not very much time. So I'm going to go through as quickly as I can, just parts of these. So first off, extended care has been kind of one of the most successful interventions we have to help promote weight loss maintenance long-term. We found that under our chronic disease model, continued support is really important for helping people adhere to those dietary intake and physical activity goals that support weight loss maintenance long-term, especially in an environment that is not supportive of those goals writ large. Current guidelines right now support at least once a month for contact, and that is what our static group, our non-experimental group, is getting her. And existing extended care interventions have been shown in meta-analyses to produce less weight regain at 12 to 18 months. However, I do want to say that the kind of pattern, that check mark, doesn't necessarily go away, but that rate of regain is dampened due to these interventions. I'll come back to that later. We're delivering all of our intervention via phone because it's been found to be as effective as in-person intervention, but can be more cost-effective. And importantly, to date right now, phone-based intervention is more effective than internet or automated approach. And this is what I was talking about earlier, related to supportive accountability theory from the digital health literature, this idea that some sort of human touch might be critical for folks to feel supported and feel accountable. And this might change as we move and have more sophisticated conversational agents, AI approaches, but for now, our automated systems are not working as well. So for behavioral skills, I'm going to focus predominantly on self-monitoring. So having folks track their eating habits, their physical activity, and their weight. In addition to attendance at study visits, this is one of the best predictors of weight loss and long-term maintenance. And generally, we recommend that folks do it every day, even though it can take some time. With that said, there's been some work on developing kind of like what are minimum thresholds that might be meaningful. And this is all from data that are from like secondary data analyses from trials. So no one's randomized folks to different number of days in these studies, but through multiple research groups and across two behaviors, we're seeing a lot of consistency such that not monitoring at all or monitoring only 1 or 2 days a week tends to be associated with weight regain, 3 to 4 days with stability, and 5 or more days with continued weight loss. And we don't have physical activity here represented just because physical activity is monitored in a slightly different way. We typically focus on minutes per week, not number of days someone's monitored. So this work, to my knowledge, hasn't been done in that regard yet. And so moving on to my last couple minutes, I'm going to talk about what's new here, what I'm excited for and working on moving forward. So we have an adaptive intervention component too. So with all of those components, I mentioned the static program. This is one where instead of getting contacts once a month, contacts are delivered adaptively. And I'll explain a bit more what that is. But first, I want to revisit kind of our conceptualization of maintenance. We might think that maintenance is someone losing weight and then kind of staying at the same weight over time, with knowing that this is an oversimplification. Folks are variable day in and day out, but this is what we might think of as successful maintenance. However, what we're seeing in the literature often are many folks, we have weight loss, but instead of this kind of solid state of maintenance, there are more ups and downs. So maybe holidays, life events, something happens, someone starts to regain a little bit of weight. What we see is that folks that are successful are able to re-engage, lose that weight, and return back to their previous nadir. And so that is this model that we're kind of focusing on. And we see especially that early recovery from weight regain may be particularly important. There's data from the National Weight Control Registry showing this, and then Jackie Hayes did something recently with WW folks and saw that people who are successful at reversing weight regain did so at lower thresholds for getting started again. So our group was like, well, can we catch people even earlier? Can we catch people before they regain weight? And the reason behind this was just through clinical observation that once folks start regaining weight, they often don't want to talk to us. We'll sometimes hear that at the end of the studies, that we managed to get people back in that just dropped off the face of the earth for a while. And we hear, well, I started slipping, I fell off the wagon, or I wasn't tracking, and I was embarrassed. I didn't want to talk to you. I wanted to get back on track, and then I was going to come back in, but then life got in the way. So we hear that story, that once folks start regaining, they don't want to necessarily talk to us, and we're not then able to help intervention-wise. So we thought, can we figure out when people are at high risk for weight regain and intervene then? And so similar to the random forest machine learning models that Bonnie Spring was talking about last time, back in 2017, I think, we started developing a predictive model of weight regain on a week-to-week basis using passive self-monitoring, using a couple brief self-report questionnaires. We optimize this for sensitivity. So we're more likely to catch people versus miss people, even if we overcatch them sometimes. And by doing this, ended up with this algorithm on the right that is underpinning our adaptive intervention. And so we're only giving folks those intervention calls if they trigger via our algorithm right now. And this is just in press now, even though we developed it in 2017, because this and the protocol paper, we kind of self-embargoed because we didn't want people in our trial acting differently because they knew how the algorithm worked, which we had people at the first trying to guess. And now the trial is wrapping up. So as I'm ending, still good on time, our trial right now, we are close to the end for cohort 4. Cohort 5 ends next year. We, like many folks, had a delay due to COVID. So hopefully early 2025 we'll have results. That algorithm paper I mentioned should be out any day now. The proofs were already returned, and the protocol paper hopefully will be out soon this fall too. If anyone has any questions, I'm happy to talk more during the discussion or later on. So as final thoughts, most people regain weight after completing behavioral weight management programs. Existing programs can help slow, but not necessarily change this pattern. So this is suggesting, similar to an NIH workshop 2014, concluded that new approaches are needed. And so that's what we're kind of having fun with now. And if anybody who's run clinical trials knows it takes a team. So I always like to thank my team as I end, funders for this trial and some of the previous development work. And I'm happy to turn the baton over to the next person. Thank you.
Excellent. All right, so we're going to have our final talk, and don't worry that we're running a bit late because we're just going to take a little bit less time for the moderated discussion. But our next talk is Allison Phillips, who's going to talk about interventions for prevention. Allison?
Yes, thank you. Just going to pull up my slides. Okay, can you see the presenter slides now?
Yes, the slides are there.
Okay, thank you, Anne. Yeah, as the other speakers have said, everybody else disappears when you have your presentation going. Anyhow, it's my honor to speak with you all today. I've been tasked with talking about interventions to promote maintenance for preventive behaviors, prevention of chronic illness. So I am going to focus on physical activity and diet, but I've also used the same intervention techniques for medication taking behaviors as well. And so I want to, instead of just presenting one study, I'm going to talk more about conceptually how would we design interventions to promote maintenance. And one way to do that is to use behavior change techniques that really promote the mechanisms of maintenance. And there aren't many theories that incorporate maintenance mechanisms in them. And it's hard to capture the dynamic processes over time. But one example of a framework or a theory that does capture these maintenance mechanisms is the multi-process action control framework by Ryan Rhodes and colleagues. So I just wanted to use this as a visual example of the maintenance processes we could target with our behavioral interventions. Identity and habit, you'll see, are at the top under reflexive or automatic processes involved in maintenance of behavior. And I know it's a complicated figure that is well worth much more time than we have, but I want to focus us in on habit. So I have focused most of my career on helping people form habits because habits are automatic and non-deliberative, consistent and frequent, which is what we need for health behavior and health outcomes. They are resistant to change, and they are in fact our default actions when we're stressed or motivation is lacking. So as a target for interventions, they're promising in terms of helping people maintain behavior. So I do want to link this to our prior workshop on measurement, because that's, as Dr. Sterrett was saying, measurement is critically related to how we intervene in behavior and how we know how we're doing. So I want to just talk for a moment about the complexity of what we're asking people to do to make themselves healthier, in particular for conditions like diabetes, not just managing them, but preventing them in the first place. And if you think about the dietary recommendations and the physical activity recommendations, they are quite complex and there's multiple behaviors involved. And so one measurement issue and intervention issue I would like to highlight is that we have to first find the habit we're trying to promote. And if we're going to focus on very specific things, or very general things, it will harm our efforts in the long term. So I have some examples for you. Habit is often measured, habit strength is measured with a self-report, behavioral automaticity index, or the self-report habit index, where you ask people about a behavior and how automatically they do it. So for example, if what we're targeting is for people to eat 5 servings of fruits and vegetables every day, and we ask them, do you have a habit of this? It would look something like, eating 5 servings of fruits and vegetables per day is something I do automatically. And that's, I mean, quite silly, although it's been done. It's too vague. It's multiple behaviors lumped into one. And unless you eat all 5 servings of fruits and vegetables at one time in response to one cue each and every day, it's not itself a habit. If instead you go more specific, eating 1 serving of broccoli every dinner while at home during the summer is something I do automatically, maybe that's a habit, but it's far too specific for our needs in terms of promoting overall health. As an alternative, I'd like to suggest one kind of simplification. If we focus on a higher order habit, which is, for example, eating 1 fruit or vegetable at every meal, something I do automatically, then that is something that could be habitual, something that we can measure, and something we could promote with an intervention that might actually have real health outcomes and in the long term. I use this for my kids, by the way. Every meal has to have strong food. Okay, so what I've termed these higher order habits. One good example is having breakfast. So if we can have a habit of, as part of our morning hygiene routine, after that is, have breakfast and then go to work or whatever the rest of our day holds, having breakfast can be a habit. But the actual food that we eat might vary, right? It could be oatmeal in the winter, eggs and toast when we get tired of that, peanut butter and jelly in the summer. You know, it doesn't matter what the specific food is. Having breakfast is the habit. So just as an example, one intervention I did a while back with students was having college students fill half their dinner plate with fruits and vegetables. That's the higher order habit, following My Plate guidelines. Now, the behavior change techniques we used were basic education on the importance of eating fruits and vegetables and how much relative to the rest of the foods that they're eating, but then action planning. So whenever I go to the dining hall, most of them have their food made for them, right? This was just to demonstrate the concept of having a higher order habit. It doesn't fit real world situations for most people, although there have now been interventions that others have done in more real world contexts. But anyhow, we wanted them to fill half their dinner plates with fruits and vegetables. We followed them for a month, and I'll just show you the results of what our primary outcome was: their self-reported habit strength, right? So filling half of my dinner plate with fruits and vegetables is something I do automatically. And the intervention group that got the action planning met the kind of threshold what we would assume is a habit being formed, because they agree is agreement with most of the statements in the measure. The control group almost always improves when you study them, hence the need for the control group, but didn't quite reach a habit threshold. I also want to just point out, I have used objective measures to assess habit strength. Some of our speakers on Wednesday were talking about how you can look at consistency of behavior in continuous behavioral measurement, but I've also used Snapchat just to get an objective snapshot of people's behaviors. So individuals who did well with the intervention, and then many of our young adults eat terribly, I will just tell you. So many just failed. And these are pictures actually from the control group. Anyhow, exercise is another complex habit, and it's hard to identify which part of the activity we want to be habitual. And a lot of my earlier work with Dr. Ben Gardner, who's here with us today, and some other collaborators has focused on, well, which parts of exercise should we promote as habit and which not? And there's, in addition to the behavior itself, which is exercising, there's the step of instigation, we call it, deciding to go exercise. And then there's the execution, actually going through the steps. But there's also what you need to do to prepare for exercise, like washing your clothes, packing your clothes, getting equipment that you need to do. That's preparation to exercise. So I have done now, well, I'm currently doing several interventions that use a multi-phase optimization strategy or a full factorial test of different habit formation components. And similar to some of our previous speakers today, one of the intervention components focuses on motivation. So really promoting intrinsic motivation, positive affect around the behavior or exercise. This figure I'm showing you is the breakdown of strategies I have just gotten data collected for with Les Mills Corporation. Les Mills Plus is an online on-demand exercise company that funded this research. They paid the participants and they paid for the data to be collected over one whole year. So what we did was randomly assign new users of Les Mills Plus to one of 8 groups. And the control group got basic goal setting, right? So we wanted everyone to have standard care in this case for forming an exercise habit or maintaining exercise. They were recruited around New Year's to take advantage of New Year's resolutions and followed for a whole year. But the three main components of the intervention was 1, promoting motivation, and I'll show you some examples in just a moment. But then we also focused on either preparation habit techniques, so habits around preparing for exercise, versus instigation habit techniques. And most of these behavior change techniques were something like the following. So for motivation, we used autonomy support, we had a set of prompts. These are just examples, but what do you want to do with this behavior? Or why do you want to do this behavior? Why is it important to you? What do you think you would most enjoy? And then to really highlight identity and intrinsic motivation around identity, what types of exercise do you think you would like to master and that you can see yourself doing? For the habits, the preparation and the instigation habits, we had them engage in action planning and coping planning. And these are behavior change techniques as part of the behavior change technique taxonomy. One thing I'd like to highlight is that when researchers use the behavior change technique taxonomy, which I encourage, just so we have some standardization across interventions, I want to note that the targets of those techniques, warning. Thank you. The targets of those techniques might differ. So action planning is a behavior change technique, but whether you apply it to exercise instigation or exercise preparation is still something that the researcher has to point out, and that's not an inherent part. The target of the technique is not an inherent part of the taxonomy yet. So that's just a point I wanted to make. So for example, action planning, whenever I have breakfast, I'm going to pack my gym bag for the day as a preparation habit. After I finish work for the day, then I will do a body pump class online. This was Les Mills Plus started the on-demand classes during the pandemic to help facilitate exercise maintenance when everybody's external contexts changed. Coping planning is focused on maintenance as well, forming these habits, but anticipating barriers that might arise and coming up with a plan to handle those barriers. So really to maintain a habit once it's begun. And mental rehearsal is also facilitates kind of automating those connections that you've planned ahead of time. So outcomes of these interventions that I've done with Les Mills, we followed, as I said, individuals over a whole year. And so as prior speakers have said, they did, measuring behavioral frequency over this longer period of time represents maintenance, but I have more specific maintenance metrics that we'll be looking at, which is the number of months until participants quit, whether they quit the study itself or quit using Les Mills. We also asked them about other exercise that they did versus these online classes, and the number of months where they're meeting frequency or volume recommendations, right? 150 minutes of moderate or vigorous physical activity per week. And we're using a subjective level of 2 weeks of elapse would qualify as not maintaining. But as we've discussed Wednesday, that's subjective. So that is the end. I just wanted to make sure I covered all of these points. I think we'll get into some good discussion, especially with the moderators and panelists later, about different techniques that we can use to really foster maintenance. But my take-home message is, if we want to promote maintenance and measure whether maintenance is occurring, we can focus on those mechanisms of maintenance. Habit strength is only one of them. There are identity interventions out there that I highly recommend, Intrinsic motivation is another one that we've heard prior speakers just today talk about. So really looking at those mechanisms and not just maintenance of behavior itself. So thank you very much. I'm finished.
All right. Thank you. So now we're moving into the Q&A portion, but also I also want this to try to be a conversation amongst those of us here present on the Zoom, but everybody who's listening, send in your questions, because it's really important to share and learn from each other, because that's what the whole point of this whole meeting is. So I'm going to read a few of the questions that are in the Q&A box already. And the first one asks Dr. Arch, but in general for all of the presenters, have you or any other presenter included or considered an identity construct in the intervention design? And all of the panelists should put on their videos so we can see everybody. Perfect. All right, does someone wish to comment on that question?
Well, I guess I'll comment quickly. I think the question was about whether identity is focused on as it's something we should promote in the intervention and whether it's measured. And I answer yes to both of those. I think those are very important. Again, I focused on habit measurement, but identity is a maintenance factor so that when even habits fail us, because contexts change all the time, especially over a lifetime, identity can reinvigorate motivation, right? Keep that up when other facilitators of behavior maintenance kind of flag.
Now, the next question, which is to Dr. Ross and others, is how do you deal with our all or nothing bias? Which is important, I think, because I think we all have that.
Yeah, so this is something that's talked about in our initial interventions, but we still bring back up on maintenance calls as support in relation to that kind of CBT orientation of our interventions, where we don't do a full CBT intervention, but we do talk to folks about common patterns of negative thoughts. And one of those being the all or nothing thinking, and how with a lot of these health behaviors, it's really important to do what you can some days. From even having discussions around with physical activity, going from not doing any activity, doing a little bit of activity, even if you're not meeting the guidelines that we're suggesting, is more important than being really active and being a slightly more active. Like if you're already running 10 miles a week, running 12 isn't going to be as beneficial as just going from nothing to walking, just having that incremental change. And so we talk about kind of doing what you can, and recognizing when that all or nothing thinking is occurring, because it happens a lot in weight management when people think I'm on the diet, I'm off the diet, and we highlight that thinking can then lead to more challenges later on, because it's hard to then get back on track if you can get off. So we talk instead about, well, you might have choices that are made throughout the day or things that happen throughout the day that move you toward closer or farther away from your goals, but that doesn't necessarily mean you're on or off track or you failed. And so we do a lot of discussion around that within the CBT orientation.
I would agree. I mean, that's part of many of our behaviors, the trajectory of behaviors. We all will stop at some point or the other, but it's how, and I think someone asked the question about identity. It's kind of like what I look for when someone says, now I don't have to think about it. And I think it's also about habit, that then I know that the behavior has taken. And then that all or none thinking also stops, because people have already got to the point of realizing that I exercise mostly, and sometimes I don't, but that doesn't make me a non-exerciser, as long as I'm doing something.
Yes, when I think about, my patients seem to live forever on the West Side. This is not being mean, but they do. But my 90-year-olds, I mean, I just saw somebody, I don't know, I think they were 99, but all of them identify as exercisers. And it's interesting because I think if there was one thing that I was going to say that my people who live the longest do, is they either exercise, I mean, their exercise has to change, right? Because they're 98 years old, but they exercise and they say, I exercise. And that's like way high on their list of how they think about themselves. And I just feel like I want to get people there, but it's hard to start at, 85 to change your habits. But exercise seems so vital to all of this. So I want to get people to identify as exercisers. I think it's important. Now, another question which I actually thought about while I was listening to you all was, and this is moving it more to the under-resourced communities, is I really like the idea of peer mentors, and I like having another person that you're accountable to. But I've done those kind of programs, but they always kind of dissolve if I don't keep them going, and I find that problematic. And so this question is how have any of the presenters evaluated how family members, significant others, caregivers may or may not have impacted the effects as moderators of their studies? And I think I try all the time to do this, but I also find it really hard to do in a sustainable way. So comments, thoughts, ideas about that?
I think the social support piece is important from peers. And I know there are some trials that have really tried to structure how you provide social support, because we can say, reach out to your family, but who knows what they are going to actually say or do, right? Sometimes they may, some people consider asking someone something an act. So you've got to be very careful about how people provide social support. And there are programs that actually provide some brief training for your support network so that they can be effective. But I think that experience of being there does help people. And one of what I really enjoy is sometimes when my participants tell me my grandchildren are exercising with me, or things of that nature, because then even though we didn't assess it, your intervention has actually spread out, impacted more than your targeted individual.
Yeah, and it's hard because family can be either supportive or the opposite at times. Like we have difficulty sometimes with folks' spouses feeling threatened by the changes that our participant is making, that, oh, are they going to leave me? Or do I have to eat like that? Or do I have to stop watching movies after dinner and we have to go for walks together? And so we have a lot of discussion around how to communicate that and how to manage that. But there have been not trials that my team has done, but trials looking at recruiting significant others or pairing folks with peer coaches that have shown benefit to that. And it makes sense because I was talking earlier, extended support appears to be really important, but if you think of the cost effectiveness and implementation side, like we also can't really do that forever. So helping people build support networks in their environment that can help them sustain these changes, I think is really important.
And I'll second that as well, Kat, that having people build their own sustainable networks, and you might think of them as habits in a way as well, having other people routinely involved and together. But I wanted to address a question also in the chat about more sustainability of, well, for example, nudges and things that healthcare providers are doing. And one of the techniques that I'm using with my collaborators is to use an umbrella hub model. So we have a hub of referring providers and other organizations, and it links up with the community-based organizations that are giving the programming. So we're doing this with Walk with Ease and Diabetes Prevention Program, and it just formalizes and provides that infrastructure for sustaining kind of communication between the referring provider and the patient who's engaging in these programs, but also like the lifestyle coaches that are doing diabetes prevention. And there's just, there are ways we can implement our interventions in this kind of infrastructure that would help them continue to be sustained. But yeah, it is hard to have the same person over, like if it's always the same provider, always the same life coach, that's even harder, right? That's, I think what you're saying dissolves. And when you talk about interventions that you try with that incorporate social support, those specific exact relationships might dissolve. But if there can be infrastructure to have some support from someone, we have used student motivational interviewing coaches. So there's always new students who are being trained in motivational interviewing, and they want to practice. And actually, older adults love working with them, even though they're basically perceived as kids, being my health coach. It's mutually beneficial for the two of them. And then there's always new students who need to be trained and want to do this. And so there's that continued support through our hub and this training program, so that it's tricky, but I think there are ways we can build that infrastructure and test our interventions at the same time.
I just wanted to comment that we're talking about maintenance of behaviors, right? But in a sense, and I think, Anne, your presentation spoke to that, it's also about the maintenance of our interventions, right? How do you sustain the intervention in order to maintain the behavior? And that's where I think Robbie was also talking about, like, how do you make this real world, and that then the researcher steps out of it and it will sustain, and therefore the behavior will sustain.
I can speak to that. I think that's such an excellent point, and agree with all that's been said. But we have been, I think a key is really not just partnering with a single provider in a healthcare setting, but either the entire system or an entire team of providers who are personally motivated to support the work. And so I presented on our work in medication adherence today, but a lot of my work in cancer survivorship focuses on mental health promotion. And for a dozen years, I have partnered with the clinical social work team in the largest oncology care network in Colorado. And they have all been trained in, or not all of them, but interested members have been trained in our interventions. And because they see that these interventions are effective, and because I designed the interventions with them to be sustainable in their social work context of, like, everything has to be group-based, only a very small limited number of groups. The groups have to take place on this day and in this way. You recruit in this way, like I'm working within the system. These interventions have become sustained within that system because I am designing for sustainability from the start, and designing with an entire team of providers who are already providing supportive care for cancer survivors. So this isn't, nothing I'm saying is new, but I did just want to put that out as an example.
No, I think that's really important. We're talking about interventions, right? But we've also got to talk about the sustainability of those interventions. How costly are they? Who's going to implement them? What's the system like? What systemic support is there? Otherwise, as Anne pointed out, for whatever reason, the second partnership just dwindled away, right?
Exactly.
How do you, and Joanne, what you're saying is absolutely right. The implementation within the workflow, within the buy-in, so it carries on when the researcher is no longer there.
Exactly.
Yes, when I ask, because I've done studies looking at adherence and everything else, when I've asked my staff, who are the people who know far better than I do because they're from the communities and work within the communities with my patients, what's the biggest problem for anything of changing behaviors? It all has to do with this stress. And I say, well, what's the stress? The stress is that their uncle's going to jail. The stress is that another family member got sick. The stress is a divorce. The stress is food insecurity. The stress is fear of homelessness. I mean, the stressors that they have are frankly so much different than my regular stressors, and that they're so big, and I don't know how to get people back on track. And I would say if you all came to my clinic in East LA, you would just hear stories that you just can't imagine were happening in their lives. And in good conscience, I can't say, focus on eating well. It's more like focus on not being killed by the Mexican mafia. I mean, it's so hard, but I think the most important thing is for me to understand the how do I find when people deviate from maintenance, and then how do I get them back on track, and how do I do that in a sustainable way in a public health system? But I can't fix the terrible things that happen in their lives, but I want to pull them back in, and that to me would sustain any intervention longer. I mean, what kinds of ways do you all have for, and I know we touched on it some in your presentations, but doing this for 3 years, 5 years, how do you do it in varied settings, and how do you connect people over time? And in the chat, a lot of people are talking about families. And again, I think that's important, but it's still got to be the person that somehow we understand needs our help.
I think our task was, and that we were talking about interventions that focus on the individual, but it's these social determinants of health, life's priorities that can just trump any of these behavioral behaviors we're talking about. If I'm in danger of not having power in my house, why would I be focusing on taking a walk? And I think the emphasis on reaching groups that suffer from many of these issues is so important. We have these techniques that have worked with select groups, but these multi-level kind of interventions might have better success with addressing some of the social determinants, the kinds of situations you're talking about, Anne.
Yeah, I agree. And I think it really speaks to the need for more CBPR level work, as you were talking about earlier, Anne, like not assuming that we have the answer that somebody needs, that they want to stop smoking, or that they want to change their eating patterns or exercise patterns. Like there might be other more critical needs first that need to be met before those things can happen. And so doing that on a community level to figure out, and there was, I mentioned, I don't know if I mentioned, I'm also in public health. I'm a clinical psychologist, but I teach in public health. And so I'm in internal turmoil a lot of the times, being an individual level interventionist and also teaching in public health and talking about, well, there's so much here that is impacting someone's capacity to engage in any of these things. And there is a history in public health more broadly of interventionists and researchers going into communities and just completely failing at everything because they're not creating an intervention that is what the community needs. And then there's really interesting examples of CBPR that kind of created massive pivots in the researchers' lives because they went in thinking, I'm going to do the smoking cessation intervention. And then they go in and they find that's not what the community needs, but we actually do have ability to help the community with what they need. And so they switch completely what they're doing and then have more success down the road because they've built that community connection. They're able to help the community meet that first need and then pivot into some of these other health behavior changes later. And so I think that not assuming that we as researchers have the answer and that we can help folks with what we know from this literature always is really important.
Well, and I think talking about weight loss and weight maintenance, on the west side of Los Angeles, we have this great tool or tools that have everybody lose weight and maintain their weight loss. And I know I can give people Ozempic and I know give people Mounjaro, and it's remarkable as long as they stay on the agent. And I'm a big believer in behavioral health because I think if you don't change your health behaviors, you're still going to not end up healthy. But to me, a lot of what we need to do is advocacy to make sure that under-resourced people have the access to the same tools. And they may not have internet connection to do text programs and everything else, but I want to be sure that they have the ability to get these agents that I think do aid in our sustained behavior change. And to be fair, in the County of Los Angeles, we've been able to do that. So you can actually get, in the under-resourced communities, you can get these agents if you need them, if you fit the algorithm for need. But it's really about, for a lot of this, is making sure that they have access to the right tools that we know we can use. But I want to say another thing, which was interesting, but just to share, is that back when I was a beginner at all of this, and I thought that I could fix people's lives, I know I can't now. I went, and a patient came to see me, and he was African American, lived in South LA, and he had diabetes and peripheral vascular disease. And I said, you need to walk. Well, he said, I can't walk because I'll get shot. My neighborhood's too dangerous, which is true. And this is a barrier that all of us have to face if you have people who live in places they can't walk outside. So I said, I thought I was genius, go get an exercycle at the swap meet, you know, because that gives you equipment. You can't go to a gym, but you can find it. So I got the thing, and he said, well, it doesn't fit in my house because the house was too small. Lots of people were living there. I said, find the one room you can. So he found the one room where he could, which was the living room. So he went to exercise on his exercycle at the swap meet, and he got shot in the leg. And the reason that no one sat in the living room was because the gangs would drive by and shoot randomly, and he got shot. Now, he didn't die, but he did have a gunshot wound to the leg. It was the worst exercise intervention I have ever made in my whole life. And I just want to point out that that's one of our problems as, sorry about the background noise, but as researchers, is to try to figure out the interventions that are truly right for the community. So I would argue that the social worker in my world is the most important interventionist, because the social worker can help me figure out what the social determinants of health are, where and how the person can do exercise, and how I can make that happen. But I really think that doing work in these communities involves not just an intervention, but a multifaceted intervention that can make the biggest difference. Now, a lot of the comments are about what I just said, about doing implementation science and behavioral science together, and how do we all create models that do this, and how do we embed them into the system. I think that the smoking cessation model is fascinating to me, because I tell everybody not to smoke, but I'm useless, right? Because I don't have something that I can attach to that gives them a smoking intervention. And the only reason I'm ever effective is because I growl at them a lot and they don't want to displease me. But other than that, do you foresee your intervention being more widely accessible in my, EHR in the County of Los Angeles? How do you perceive making it more implemented more broadly?
Sorry, I'll come up here. Sorry. Yeah, I don't recall growling being an FDA-approved approach, although I sympathize with you there. And what you said was actually quite consistent with evidence. Clinicians, mostly physicians or other healthcare providers, are actually excellent at what we call the first 2 A's of the 5 A's approach: asking and advising. They're great at it. Over 90% of the time, when a smoker comes into an office, they're correctly identified as a smoker, and they're encouraged with very firm, maybe growling language to quit. But then it's the assist is the next A, and that's where, unfortunately, implementation breaks down. And there's lots of reasons for that. From our perspective, there are a lot of heuristics that get in the way. Culpability bias is one that I didn't have time to go into. But unfortunately, I think many people misunderstand nicotine addiction and believe that there's a lot of sort of rational choice involved in the decision, and that's not necessarily the case. So that's an important bias that gets in the way. Misunderstanding about side effects of medications like varenicline gets in the way. If you have one patient who had a very negative experience with the medication, and there's overriding concerns about risk and liability, it's easier to stick with treating blood glucose levels or cancer or asthma, whatever it is, that's your wheelhouse. That's where you feel comfortable. So it's about designing systems that, from our perspective at least, that can acknowledge those biases that get in the way of moving on to assist, and developing systems that make it easy to make those kinds of decisions from the clinician. I don't want to suggest it's only about the clinician and it's only about the system, but patients have ambivalence and reluctance as well to engage in tobacco treatment. So it's about developing, motivational interventions to pull them into treatment. But what we've been trying to do is to develop changes into the electronic health record that can be transportable to lower resource settings. I know we fully acknowledge that we probably have one of the wealthiest health systems in the country, and I have a lot of personal professional resources at my disposal to make this work feasible. We're going to try and do some of this work in FQHCs across Philadelphia if we can get our next grant funded in that space. And so we'll see what adaptations are necessary to move into lower resource settings to try and replicate what we've been doing.
That would be really helpful. And I think that there are big healthcare systems that have, EHRs that we use. I mean, one of the problems for me is that I hate the EHR because all it does is fight me. And second of all, it so rarely is useful. And, it gives me, every time I try to order insulin, I get 6,000 warning signs. And then I have to scroll through all those, and it doesn't move me to action. My behavior is not improved by the system. So if you can, I love the tool that you had. So if that could work in more settings, now we need it for the other areas in which we're going to change behavior. But I think that it's.
Yeah, and I would say, and that we do engage in a lot of user-centered work initially. We meet with a lot of clinicians who have very passionate ideas and concerns about the EHR when we're trying to develop these kinds of systems to get their perspective, to make sure it's something. I'm not a clinician, so I don't know what it's like. It all seems very simple to me, but it's not.
There is nothing simple when it involves the EHR. I can't do it. I do it all on my laptop, and I just put the laptop aside, and I'm just like an old school physician. I can't take the system. I do it all later at night or something, but it's just hard. The systems have to be simpler. All right, so we have just a few minutes left. Any of you may want to make one last comment to me and the group about what your interventions do and how they can help out here in the world of under-resourced patients and trying to improve outcomes?
I think I just have a comment about how we design our interventions and to think carefully about starting with maybe low cost, low intensity kinds of programs first. And then if those don't work, to ramp it up, because we all have there are limited resources. And if we want this intervention or intervention component to be disseminated, I think we need to think about that right from the start.
I also want to emphasize, Anne, I loved how you said that in LA County, you can now get weight loss medications in East LA. And I'm assuming that was a political or a policy level change that facilitated that. And I think it's so important not to overlook those levels of behavior change. We just published in the Journal of Clinical Oncology a meta-analysis of 370,000 breast cancer survivors and what worked to sustain behavior change in taking adjuvant endocrine therapy. And the most consistent studies that produced change were the policy changes that lowered the cost of the medication. So it's very humbling, as many of us are psychologists or physicians, to recognize that much of that change is happening at a much higher level than we typically work. But we can bridge to them.
And we see that in our field as well, too. I think there was a review of interventions from nutrition at different levels and found that individual level interventions were most likely actually increase health disparities, because it's kind of the rich get richer. People who already have resources are then able to use these interventions and have even better health outcomes, whereas the policy level is really where you start seeing greater benefit. And that's where I was saying I'm this inner turmoil as living both in the public health and the clinical psychology world, is I feel like sometimes I'm just fighting against this tidal wave of environmental and political and social cultural factors that are making it so hard for people to meet the goals that they want to meet. And so like, we're trying to arm them with, here are all the skills that we have that can help you overcome this. But it's like that old story of like the dam breaking and like you're trying to put your finger and like you can't stop the deluge of all these other influences on eating activity as you go through the day, between advertising and food engineering and costs of foods, and just, yeah, I could list things for about an hour. But it's like what we have, we're doing the best we can to arm people, but it's really a drop in the bucket compared to the type of change that could be made further upstream.
Yes, Allison, do you have any last comments?
I'm answering everybody's comments in the chat.
I know, I saw that. That was really good of you.
I've been having lots of conversations on the side, so I apologize.
No, you're doing great. I saw. But I think that this has been a great discussion, and there's so many more things to talk about. And I also think, oddly, that the reason in part that the change has happened in LA County is because literally there's been a committee of us for 20 years who's worked together with primary care and subspecialists, and we work with the Department of Health Services, and it takes tremendous patience. And one of the benefits is that of the committee members, I'm the only one who doesn't just work in the county. I'm the only person who's at USC, so I work in both sides of town. So I'm the thorn in the side of the county because I say, this works, and you're worsening healthcare disparities if we don't have it. And so takes years, but any of you out there who have any capacity to change systems, if you can, it works. And then they give us the GLP-1 receptor agonist and the formula, and then our committee writes the usage guidelines and how we do it, and we meet with the people who pay for it, and we figure out the costs and everything else. But there are processes, I think, that we can all make change. And then I also go back to Sacramento and try to change policy for the state. But I think if we don't do that, then we're missing like 50% of what we should be doing. But you can't be impatient, and you always have to smile, no matter what they say to you. You have to just be nice, because otherwise, but now the county, the whole state gives you CGM. I mean, we've really made changes, but I attribute it because of the people I work with in LA County. It's been a phenomenal group. And again, I haven't ever left. I've been here. They know me, they trust me, and they know I'm not going to go away, which I think has really contributed a lot to my benefits. All right, so now, Sydney, we're going to
jump in
go
here
to a break.
Yes, thank you so much, Anne, and to all of our panelists from this first session. We're going to take a 20-minute break now, and we'll resume around 1:20 Eastern time. And when we come back, we'll move into our second panel session of the day, where Dr. Pascal Sheeran will moderate a session on what's next, addressing the gaps in intervention science on behavioral maintenance. So thank you all for your engagement so far, and we'll see you back here in about 20 minutes. All right, I think we'll go ahead and get started with the second half of the day. So welcome back, everyone, and thanks for sticking with us. I'd like to introduce the moderator of this next panel session, Dr. Pascal Sheeran. Dr. Sheeran is a professor in the Department of Psychology and Neuroscience at the University of North Carolina at Chapel Hill. Dr. Sheeran, the floor is yours.
Thank you very much, Sydney. Okay, so this afternoon we're going to address ideas about where research on behavioral maintenance should go. What are the gaps in the literature? How should we intervene? What work needs to be done in future to improve rates of behavioral maintenance? When I think about interventions, I tend to think the fundamental metaphor for behavioral interventions is we're trying to push people to change. And I think one of the things I really learned from this morning's speakers, and I kind of want to thank them for this, is that in pushing people to change, in trying to get people the requisite levels of motivation, self-regulation, or habits, we may be neglecting a couple of things. The first is, we can ask the question, why aren't, rather than asking kind of how do we get people to maintain their behavior, we can ask, well, why aren't they already maintaining their behavior? I think this morning's talks offered a kind of interesting perspective on the friction that people face. That actually many social determinants of health really stand in people's way. And that it's not enough to push people, but also to reduce the friction to enable their change. And the second thing that I took from this morning's talks was the importance of critical moments. I think Anne's talk kind of demonstrates that, of course, if you don't have access to fresh food, you can't eat it. But just because you have access doesn't mean at that key moment where you're choosing between an apple and Doritos that you will choose the apple. Similarly, Robert Shaw demonstrates that a nudge at a critical moment to providers is enough to kind of make a dramatic change to whether or not people get optimal medication for smoking cessation. Bernardine Pinto's talk indicates how valuable sustained intervention over time is. Either weekly or monthly continued calls continue to benefit people's behavior. Similarly, Joanna Arch's talk demonstrates when I look at my medication, I've actually got a relational motivation. I'm doing it for this person at that critical juncture. Catherine's work is very exciting on the potential to identify lapses kind of in advance so that one can time one's intervention. And I really like Alison's work, which is that actually the timing for behavioral maintenance is not just at the moment of exercising, but also in the sequence of behaviors that lead up to that. What key behaviors, preparing to exercise, washing one's clothes and so on, or deciding to exercise are really crucial. And I think one of the things that I think the upshot is that we're at the moment kind of very much in push mode. And I suspect we need to pay more attention to friction. But I think we also need to pay attention to the idea of scaffolding. What is it we can do to help people at that critical juncture? Yeah, how can people talk themselves in a moment of lapse into continuing to perform the behavior? What happens when one's power is restored, or when one has access to food? How does one reignite, if you like, one's motivation, restart, reinstigate one's habits? And there may be interesting questions about activating these concepts, but also about our attributions for lapses. Do you take kind of this evidence that you haven't eaten healthy today as evidence that you can't do it? And what work could we do there? So these are my initial thoughts about where directions that interventions may go. We have a great lineup of speakers who've agreed to share their thoughts on what next and what are the gaps in intervention science. We have 4 speakers, and we gave them a set of 8 questions. And just to make things interesting, we're giving them 5 minutes each to present. So we're asking them to do the impossible. They can only really address 1 or 2 of the questions. We're going to use these questions to structure the discussion with the panel, but we're inviting the audience to use the Q&A button at the bottom of your screen to pose questions. And I also encourage you to use the reaction buttons to clap, give a thumbs up, or if you've got something to celebrate, to celebrate. So biographical information and key papers from our 4 speakers are available on the workshop website. Our 4 speakers are Dr. Elva Arredondo, who will talk about engaging organizations and communities to promote maintenance. Dr. Don Edmondson will discuss motivation and broader contextual influences on maintenance. We'll also highlight resources from the Science of Behavior Change Initiative. Dr. Ben Gardner will discuss the interplay and relationship between maintenance and habits. And Dr. Rena Wang is going to share insights from her extensive program research on maintenance. So can I please call upon Dr. Arredondo to offer the first presentation?
Wonderful. I'm going to go ahead and screen share. Can folks see this? Oh, good. Okay. Let's see if I can. It makes it tricky when Zoom's icons are covering the presenter mode. So this might be the best I can do for now. Okay. Well, good morning or good afternoon, depending on where you are. It's wonderful to be part of the workshop and to hear some of the wonderful work that the panelists presented, as well as the discussion that followed. Today, I'm going to be focusing on sustaining health programs in community organizations, and more specifically in churches. So this aligns nicely with some of the work that Dr. Scholl and others presented on where implementation science has been really helpful. So I'm going to be focusing on some strategies that we're implementing right now in a trial that involves 32 churches. So I'm going to get to that in a minute. And we know that in community-based approaches, we not only want to create opportunities for people to start the behavior, but we also want to have strategies to help sustain the behavior. And organizations can create those supports for individuals. So what do we know about sustainment at the organizational level? Well, we know from research that most interventions don't continue after a year. So this is a problem. And so what do we need to focus our work on sustaining programs? Well, certainly the most obvious one is to make sure that we continue to improve health outcomes and improve health equity, and make sure that people have longer and better lives. We also know from the community perspective that it impacts trust. I've been in a number of conversations with community leaders where they anticipate researchers to come in, do the project, and then once the project ends or the research grant ends, the project tends to end. So they don't want to see this as a short-term collaboration. They really want to see this as a long-term collaboration. So, and we know that most do end when a grant ends. But it also makes economic sense. We want to make sure that the investment that we put in these organizations yield long-term benefits. So when these programs end, the benefits stop. So we really want to pay attention to sustainment. So some of the work that my team and I have been doing involves around promoting physical activity in churches. So in a prior trial to the one that we're doing right now, we tested the effectiveness of a faith-based physical activity program in Latino churches primarily. And we found it to be effective. So then in this trial, we want to be able to not only optimize the implementation, but also be able to figure out some strategies to help sustain the program. So this program involves training community health workers or promotoras to lead physical activity classes. And it also engages church leaders to help support the implementation and sustainment of the program as well. And we enroll primarily women in the trial. So part of the work that we're doing here is, let me go to the next slide, is really thinking about sustainment from the beginning. And this is some of the work that Dr. Ash mentioned, is thinking about starting with the end in mind, right? And thinking about, well, what do we want this program to be once the grant ends? So there are a lot of different strategies that we're thinking about at this point. And these are all based on evidence from research and also informed by the dynamic sustainability framework. So prior to implementing the program, we're meeting with church leaders to understand, well, how can this program better align with the mission or the values of the church? And we want this to really be in good alignment, because we want church leaders to see that this program really benefits and is in really good alignment with the church values. So we do a lot of qualitative interviews to really understand how we can best do that and adapt the program prior to implementing the program. So some of them tell us, well, health equity or equity is important. So then we talk about in the program, or we adapt the program so that it has a more equity focus on the importance of improving people's health and making sure that physical activity is accessible to everybody. So we really take on those nuggets and that information from those interviews to figure out how we can really align the program. Some of the church leaders tell us, well, mental health is an important value for our church. So then we link physical activity with mental health. So we really want to make sure that this program is as relevant to to the context in which we're working with as much as possible. So during the implementations, once we sort of adapt the program during the implementation, we know that churches that are connected to outside resources are more likely to sustain programs in general. And we know from literature that organizations that are connected to outside organizations or connected to other community organizations tend to have more resources, more information, and tend to, in that process in itself, helps facilitate the sustainment of programs. So what we're currently in discussions with church leaders to figure out ways in which we can connect the church to the health department or other YMCAs and other organizations that may have resources that could help sustain the physical activity program once the grant ends. So we're in the process of trying to make those connections so that other key stakeholders who see a benefit in working with churches can really help support a lot of the programming that's right now in the process of being implemented. But we also know that that the active period of implementation is going to end at some point, and we want to be able to think about, well, what do churches need once we pull away, or once the research group pulls away to help sustain the program. So we are not quite there yet because we're in year 2 of this trial, but we're going to be developing technical support strategies so that if a church needs specific resources, they have a go-to group that can provide them with some of the technical resources to be able to continue to sustain the program. So we know that there are going to be some needs. We don't understand what they are yet, but we're anticipating that they will be there. So once we get there, I'll have some findings to share, but we're laying the ground to try to set that up for the sustainment period. So so these are a lot of these concerted efforts that we're implementing at the organizational level, and we want to be able to not only launch programs successfully, but we want to be thinking about, well, what's needed during the implementation to help lay the ground for sustainment long term. So I'm going to pause there.
Thank you, Dr. Ordonda. This is a level of analysis we don't hear enough of, so thank you for sharing that research. Can I please now call upon Dr. Edmondson, please?
Thank you. I'm just sharing my screen here. Yeah, I feel really honored to be a part of this group, and I feel like the questions are really excellent questions that we were provided. I chose a few of them to discuss. My name is Don Edmondson. I'm at Columbia at the Center for Behavioral Cardiovascular Health. I've tried to lay out some sort of provocative questions or answers to the questions that we were given. One of them was, why is maintenance rare? Why is behavioral maintenance rare? And I think one of my kind of foundational beliefs about people is captured in an idiom. I'm not doing this for my health, because people don't do things for their health really, or they don't do them for long for their health. Sometimes they'll have a health event that's really scary and like, oh, I really need to change. But what we've found in our research is that a lot of people actually, when an event is too scary, they avoid the physical activity, they avoid the medications for some of the reasons that were discussed earlier. I think Dr. Arch mentioned this notion of having this relationship with the medications. So we then try to think about, okay, how can we connect these behaviors to a higher purpose? One of the things I liked about Elva's proposal, I personally don't have a church or sort of religious group to connect to, but I do think that there are other sort of secular higher purposes available, in particular, thinking about climate change and sort of connecting how our health behaviors are related to the world around us, or being available for other people in our families and our communities. So I've been thinking quite a lot about that. Also, obviously, the socio-cultural context that we live in here in the United States, the sort of atomization that our brutal capitalist system has continually pressed on our individuals, on our families. And so when we think about comparing the way that our individual sort of actors, the people that we want to be engaging in health behaviors, think about those behaviors, perform those behaviors, comparing that to other more collectivist societies or even to intentional communities within the United States. I think we're living in a moment, a historical moment, where we're seeing an increased push toward collectivization, in part in response to the continually exploding sort of inequality, wealth inequality in the United States, greater recognition of the racial and ethnic disparities in wealth and every other sort of measure of well-being. We've seen, I believe, a tripling of the number of intentional communities in the United States over the past decade. And what we found and what little research exists is that people in those intentional communities tend to have very high quality of life, engage in health behaviors, and have general better health. So should we, another question that was asked, must maintenance interventions be tailored to context or address cultural barriers? I think it's clear that the answer is yes. We know that neighborhoods largely determine health behaviors, and I don't need to repeat this for you. And also, we're living in a historical moment, unlike any other, in that we know that climate change is differentially impacting people and places that already have the highest barriers to behavioral change and maintenance. And we know the pathways by which those health behaviors and health outcomes are being undermined. And we know the places in which those are occurring. We also, for the first time in human history, based on physics, actually know the future. And we know the future will be worse than the present with respect to the environment in which our societies, which were designed for an entirely different climate, are going to have to be performing. So as a field, the behavioral sciences must incorporate this knowledge to remain relevant and to keep the health disparities we talk about wanting to address from exploding further, and do that by becoming a more local science and a more climate and context aware science. So the third question and final one, must interventions be disease or behavior specific? My argument is climate conversion, becoming aware that diet, physical activity, health disparities, and our sort of relationships to meaning and purpose and community engagement can all be understood as part of our individual reaction to the historical moment we're in, to the climate change moment that we're in. And there are some example citations here of how to think about our science in that context. Similarly, the living and working and sort of behaving in a more collectivist manner, and structure policy and corporate interventions to foster this sort of collective engagement. We know that when we have support from others, when we have compacts or agreements with others to perform behaviors, we tend to maintain them better. That's my provocative piece. Here's the resources. There's the scienceofbehaviorchange.org. We have a measures repository there that is really outstanding, both in terms of being able to download and sort of access behavioral measures, mechanisms of behavior change. It's sort of a beautiful clearinghouse that's also integrated with other things like Experiment Factory, like the Human Behavior Change Project, with the BCTs and Behavior Change Technique Wheel and all that. So that's a really great place. Go and use that. And the newest tool we have, I think, is going to be something like the consort diagram or the PRISMA checklist is for other types of science, for behavioral science, specifically mechanistic behavioral science. There's a couple of links here, but it's really, really useful. There's a video, the bottom link is to the video that describes it. The Burke et al. Link shows the development paper. But I think soon journals will be requiring something like this because it's just too good and too easy to follow it. Thanks, everybody.
Thanks very much, Dr. Edson. That was really interesting talk. Our next speaker is Dr. Ben Gardner. Particular thanks to Ben for giving up his Friday evening in the UK to speak to us about habits and behavioral maintenance.
Much. Let me just share my screen. Okay. I see what everyone else is saying now about the screen looking slightly odd. But I'm going to assume you can all hear me. Okay, so I just wanted to make really one point which picks up on something that Alison Phillips said earlier on, which is really just about definitions, the definition of habit, the definition of habitual behavior, the definition of behavior maintenance. And I think it's important that we understand these definitions, because the way that we sometimes talk about behavior maintenance, we use it in a way that's synonymous with habit. And what I'm going to argue just very quickly is that actually the two are not synonymous. And when you do start to treat them as synonymous, you run into problems. So first of all, what is a habit? If you look in the dictionary, well, the Cambridge Dictionary, it will tell you that a habit is something that you do often and regularly, sometimes without knowing that you're doing it. So if we just focus on that for a second and think, okay, so what is a habit then? According to this definition, a habit is a type of behavior. It's something that you do. It's not just any behavior. It's a behavior that you do often and regularly, so there's some element of frequency. It's something that you might do without thinking about it, so it's automatic. But nonetheless, the key point is a habit is a behavior. But this causes a problem because to the psychologist, sorry, I can't even progress now. Okay, all right. To the psychologists, we've kind of we've been trained in models that tell us why people act in the way that they do, and this is a portion of a model called the Theory of Interpersonal Behavior by Harry Triandis, which he published in 1977. And what he argues in that theory is that habit is a cause of behavior. So immediately we've got a problem in that if we're treating habit as the behavior, we can't also see it as the cause of behavior. And this is something that's been argued for many years. You can't treat habit as a determinant of behavior, yet also treat it as a behavior, because then you're saying the cause of behavior is behavior, and then you just kind of end up getting slightly confused. So within psychology, we have what we feel is a more kind of sophisticated definition. And by the way, I should say there's no correct or incorrect definition to any of this. I mean, some people in their talks so far have talked about habits when they mean behaviors. Some people like Alison Phillips have talked about habits in terms of specificity and in terms of types of association. There's no correct or incorrect definition. It's just whatever's useful. What I'm trying to argue here is that actually we've got different definitions, and we need to recognize that we're sometimes switching between definitions, and that has implications for interventions. But for the psychologists, we define a habit as an association that we formed between a situation and an action that we do in that situation. So one association that many of us have is we go to the movie theatre, we eat popcorn. It's something that at some point in the past, we encountered the movie theatre context, we decided to have popcorn, we found that a pleasant experience, so that reward reinforced a very basic association between going to the movie theatre and having popcorn. And each time you do that behaviour in that particular context, so this association develops. And crucially, what happens is after a number of repetitions, this association strengthens to the point whereby just entering that context, entering the movie theatre, automatically prompts a kind of unconscious want or an impulse for you to do the thing that you normally do in that situation. So you arrive at the movie theatre, you're not thinking about what you want to do anymore, you just automatically experience an urge to eat the popcorn that you always eat. So to the psychologist, we see it as a learned cue behavior association that triggers an impulse for us to act. And the reason I like this definition, again, nothing's correct or incorrect, but the reason I like this is it kind of corresponds more with that model that I showed you earlier, because this treats habit not as a behavior, it treats it as a cause of behavior. So then we need to start separating these things out. And this is what I think is really important for behavior maintenance, to actually start separating out these concepts. So I've just argued that habit is a learned cue behavior association that automatically triggers an impulse to act. So what happens then is that when you have this habit and you go into the situation that's part of your association, that triggers the impulse, which, as long as you don't fight it strongly enough, translates into habitual behavior. So habitual behavior, the thing that you do is not the habit. Habitual behavior is the outcome or is the result of the habit being generated. So we can distinguish between the habit, the underlying association, and the habitual behavior, the thing that you do out of habit. And then we have to consider, well, what does behavior maintenance mean? Behavior maintenance, as I define it very simply, would be continued performance of a behavior. I'm not getting into the kind of the details of this, but you can see that behavior maintenance is not necessarily the same as habitual behavior. And the reason for that is that not all the behaviors that we maintain are being maintained by habit. And that is the crucial point that I'm trying to make here. Habit, as the psychologist understands it, is only one mechanism for behavior maintenance. Many of the things that people do successfully and manage to maintain over time, they're doing them not because they're habitual, but because there are other mechanisms that are keeping people on track. And that's exactly the point that Alison Phillips was making earlier. Some of these other mechanisms include, for example, pleasure. It might be that you like it, and so you're thinking that you'll do it because you like it. Status quo bias, or in other words, inertia. It's the thing that you normally do, so why not do it again? Also, what's been called taste discovery. You discover a liking for this new behavior when you do it more often. And lastly, to conclude, I mean, the reason this is really important is that actually, if we just kind of term behaviors habits and we say, how do we get people to form habits? But we're actually referring to behavior maintenance. What can happen is you then might think, okay, well, let me go and read the literature on habit. But the literature on habit is literature on cue behavior associations. And if you go along with that literature, you'd think, well, actually, what I have to do is automate these behaviors. I have to make people do things automatically without thinking about it. But what I'm trying to say is I don't think that we do. And in fact, we don't want to automate things because a lot of the time it can take the pleasure out of it. Anyway, that's everything from me. But if you are interested in this, this is a wonderful paper that really articulates this really well. It's published in 2020 by Volp and Lowenstein, who just argue, or they set out very eloquently, what the many mechanisms are that can produce sustained behavior change, as well as forming a habit.
Wonderful talk. Thank you so much, Ben. Our final speaker is Dr. Rena Wing. You need to unmute.
Great. Okay. So I'm going to, for once, speak without slides, in part because I wanted to be able to respond to what people had said earlier, but also because I felt like this was really just to generate some discussion. So I wanted to first begin by commenting a little bit on this habit versus behavioral maintenance. And I want to come back to the idea that someone had raised before about the importance of identity, seeing yourself as an exerciser, or seeing yourself as a successful weight loss maintainer. That seems to be a key part of this whole behavioral maintenance that I don't think we understand yet. I don't think we understand how do we get people to view themselves as a successful weight loss maintainer. I don't know how we get people to change their identity. But I mentioned yesterday in one of the comments I was raising was that there are people who are vegetarian or people who follow a kosher diet, and they do it all the time. They maintain this beautifully for years. Maybe they go off it once in a while with a lapse for some reason, but they get right back on it because this is part of their identity, I would argue. So I think that's an important distinction, okay? Another thing I want to emphasize today is that designing research in this area of behavioral maintenance can be very hard because they involve long-term studies. In weight loss, we typically do a 6-month program, and we're looking at maintenance like through 18 months at least now. Many of us are trying to look at it through 30 months. That's a long study. It's a long NIH grant. And it really makes it tricky to understand how people maintain their behaviors. Finally, I just want to tell you a little bit about a program that we've been doing called RX Weight Loss. which is a program that is offered to people online to help them lose weight. It includes 12 educational videos, self-monitoring, and then automated feedback on their self-monitored behaviors. Okay. So it touches on all the things that Kat Ross was saying was crucial and others had pointed out too. We know that it works if a person uses it. However, I see two problems, and I really think one of them has not been discussed at all, which is that most people won't even enter the program. Even though we offer this program, we have put this program in doctors' offices. We have put it there for free for use by patients. We have said to the doctor, just refer your patient. We'll screen them, make sure it's okay, and then they can use this program for free. Okay. We find that the vast majority who are referred by their doctor, the doctor says, hey, Mrs. Jones, you should lose weight. Here's a good program. I'm going to encourage you to use it. Do not enter the program. Okay. So if they enter the program, they'll do well. But if they don't enter the program, they're not going to do very well. Okay. They're not going to lose weight at all. Okay. Now, another issue that we have faced in this programming of this research on this RX weight loss, we did a pragmatic program where we were trying to put it right, as I said, in the doctor's offices, where they could refer their patients and then it would be free. We have found, I neglected to mention one thing. We compared two maintenance interventions here. One was the monthly maintenance program that people have been talking about today. But another came from this idea of occasional refreshers. That maybe what we should do, especially for weight loss, is not just occasionally have a monthly meeting, but rather group our meetings into little like months of meetings. So we'll wait 4 weeks and then have 4 weeks of maintenance in a row. So you have 4 weeks off and then 4 weeks on, 4 weeks off, 4 weeks on, okay? We argued that might be a better approach to maintenance because you could vary what you're teaching people. You could perhaps have greater motivation when they went back on, etc. We compared those two strategies with a usual care, more like maintenance program where people just were sent written materials once a month. We found that the written materials did not help much, but both maintenance strategies worked equally, and they worked both pretty well relative to the non-treatment control, or the usual treatment control, I should say. So I don't believe that just how we pace our interventions is going to matter as much as we had always thought it would. But I do think that this brings us back to the idea of this notion of why people don't restart a program. Okay. So to me, maintenance is sort of a misnomer because I think what we were saying before is that people go off their diet, off their exercise, but then they re-get it. They get back on it. And my question is, why is it so hard for people to get back on their program? Okay. Weight Watchers is the only program I know of where anecdotally people will say, oh, I've gained a little bit of weight. I'm going back to Weight Watchers because I know it worked. For the most part, people don't want to go back onto a diet that worked for them before. We found that even with very low calorie diets, when they were extremely successful, we'd put people on VLCDs for 12 weeks. They'd lose a lot of weight. We'd take them off for 12 weeks. During the 12 weeks they were off, they would cry, please put me back on. It was so easy. I was so good on it. It was great. We'd put them back on and nobody adhered. Nobody lost weight. Okay. So I think that's one of our big dilemmas is why? Why is it so hard for people to restart on weight loss or on any behavior change that they've been on? I think, by the way, that's going to be a problem with these JEDIs. We're all talking about how JEDIs are going to be so helpful because we're going to be able to catch people before they actually relapse using our systems and identify who is about to relapse and then give them some great helpful hints or some nudges, whatever we want to call it, or some treatment. I don't think at that point most people are going to want treatment. I don't think they're going to accept treatment. At least that's been my experience. Now, maybe if the JEDIs occur early enough, far before any of the behaviors are starting to unravel, it's going to work. But I don't know how we're going to be able to do that, really. So I guess that would be my concern as we go forward. And, we're thinking about how to design a study or how to design a program really that's going to help people restart. Is, really what is maintenance? Is it a continued doing something all the time? Or is it something that you do infrequently and then you do frequently for a while, then you go off of it and you go back on it? And that would be the design. One of the questions we were asked is, if NIH gave us $5 million, what would we be interested in doing? And that's what I'd be interested in doing, I guess, would be playing with this idea that you have to wait for a person to be motivated, or you have to identify when they're most motivated to restart and then see how to help them restart. It's a very different image, I think, of maintenance than what we usually have. So those are my comments. So just hopefully they're helpful.
Thank you so much, Dr. Wynn. That's a really interesting analysis of maintenance. I really like the idea of continuous restarting or sensitive points in the restart process. I think we're going to share now Sydney, I think, will share the slides that we actually shared with the, I think it's the next one, there we go. These are the questions that we kind of posed to our discussant. And I think hopefully these questions might find an opportunity, give us the opportunity to discuss kind of where next in broad terms. Please add any questions or kind of issues that you think we need to address to the Q&A. So our first question was, why is behavioral maintenance rare? And what factors and processes are neglected or underemphasized in theories and strategies of behavioral maintenance? So I think Dr. Wing and Dr. Edmondson has kind of addressed this issue to some extent, but do our other discussants have points that they'd wish to make in this regard? Yeah, Ben?
Sorry, I don't know if I'm being too analog, putting my hand up in real life. I think one thing that I'm surprised is always neglected is that things change, people change, the inputs that influences on our behavior change from one moment to the next. And this is something that I think I kind of lament as a psychologist, that, we are trained to see things in quite simplistic terms. If you've got an intention to do something and you measure someone's intention in the morning towards doing something later that day, we expect people to adhere to that. But the fact is, life's chaotic, people are chaotic, there's a lot going on at any one time. And I think what's quite interesting is looking at those studies that do track changes within people over time. And going to that question of what would you do if you had $5 million, I'd love to do a study where you kind of follow someone around and just ask them at any one moment, why are you doing this, why are you doing that, why are you not doing that? Because I think there are different influences at different times, and I think that temporal aspect and that chaotic element is kind of missing in some of our theories at the moment.
And for me, at least where I am in terms of my research, I'm looking at it from a systems perspective and organizational perspective, and seeing how it interacts with some of the other levels of influence, like the individual and the interpersonal level, because we know that group support plays a role with maintenance. We know that if the organization provides opportunities to be active, that's going to help facilitate that. So I think the integration of multiple levels in one, we know we have the social ecological framework, but it seems so general. But in terms of predicting maintenance, to me is maybe an opportunity for further exploration.
I think there is an individual differences issue here that kind of is important to consider. There's no doubting that kind of our measurement practices necessitate that we kind of measure intention in the morning and behavior in the evening, and it would be desirable to continuously measure kind of people's goals or self-efficacy and so on. But but some people do act on those intentions. And some people don't. And I think some of the goals of our theories is to understand kind of, well, what is it that's enabling one person to do so and another person not to do so? Two people in hugely disadvantaged backgrounds, one may be able to take their medication, the other person isn't. there's a sense in which there is a mystery about kind of how some people are able to kind of maintain behaviors and other people are not. And I think part of our goal is to figure, well, what is it? Not merely, you know what I mean? Of course, the person's kind of social and economic circumstances will have an important bearing. But at the same time, even people in Sweden struggle with behavioral maintenance. And what is it that we can give to people that would kind of increase their odds of acting on those intentions? Do you think that might be a goal?
I don't think, though, this is Rena Wing. I don't think that it's going to be an identity alone. I mean, a person-specific thing. Because I think you're going to be adherent in one behavior, maintaining one behavior, but not in another behavior. So it's going to really be a person by behavior, by time kind of interaction. It's going to get very tricky to study. Because, I don't believe the person who is necessarily adherent to exercise is always going to be adherent to their diet too. I don't know that they're going to go together all the time, or smoking.
Can I look to the second part of the question? So what particular processes or factors do you think maybe we're not giving sufficient attention to? I think identity was one. Are there others?
Sorry, just to jump in, I think this goes back to the point that I made earlier. I think it's recognizing, as I said, that people change. And actually, after you've started trying to do something, you may well change your mind. And, Alex Rothman wrote about this years and years ago, the concept of satisfaction, that things look differently on the other side. You give something a go, you might maintain it, but actually it's not what you thought it would be. I think the other thing is that, and someone made this point quite early on, that we've got to recognize that although we're interested in health behaviors, people don't always do them for health reasons, and they've got other priorities as well, which goes back to this point about we're oversimplifying things. If we ask, why are people not doing this behavior, in fact, it's more a case of, why are they doing all of these other things? What's so important about those? And can we get this behavior to fit in? And this is something I've been working on, some kind of very early work that I've got, which is about trying to understand people's routines, trying to understand what people are doing, in what order, and then thinking, can you insert a little bit of this behavior that you want them to do into that routine, so you lock it into what they've already got in place, rather than walking in there and saying, right, I think you should change this behavior, so go and do this, with no consideration of what they're already doing and what their priorities are.
I think the other point that was said before by Don, I guess, was that behaviors aren't always changed for health reasons. That's not a great reason. So I think we also need to understand what other things are motivating long-term maintenance on an individual level.
Since Deborah asked me to address the collectivism as an under-researched mechanism, I think, and this is related to things that both Dr. Wing and Gardner have just mentioned, but I think that people are doing a whole lot of things, but they're not going for runs very often. And going for a run is miserable, because I've done it. I hate it. I hate running. I don't like just going off by myself and running. And also other people don't really run the same sort of speed that I do and whatever. But I'm very happy to go over to my friend's house and help them move house, or I'm happy to go and do some gardening with them, or help them do stuff, and so there's a way that this sort of like atomized me in my apartment with my phone, binging and doing. Also, Netflix is amazing. There's so much stuff to watch on there. My couch is super comfortable. The air conditioning is great in here. Like, I could never leave this apartment. I'd be fine. But I have a postdoc that just joined our group who had started a co-op in California before she moved. And she was just telling me the other day, I can tell that my sleep is already impacted by being here in an apartment by myself, because I used to live with people where somebody would say, okay, I'm going to bed. And I'd be like, I'm going to go to bed too. Also, they divvied up their who's in charge of meals that day. And so on whatever day was your day, you would do a good job with it. You would make sure it's healthy for everybody. And these are just like very, very old human, like we came up in small groups that were related, in some sort of way, shape, or form. And now all of a sudden, because our system wants us to buy as much crap as possible per person, we've been taught or learned or whatever that living by yourself or in as small a group as possible is the best way to live. And it's just demonstrably not the happiest way to live for the vast majority of people.
Thank you. Can we move to the next question, please? So I think Ben spoke to this. Has anybody got any additional comments about the relationship between habits and behavioral maintenance? I think, Ben, your idea, I was intrigued by your idea about kind of fitting kind of health behaviors into people's routines. So it sounds in a certain sense that you're talking about the idea that kind of micro habits kind of could actually contribute to health maintenance.
Yes, exactly that. The idea that, I mean, some of the work that I've done with Dr. Phillips that was mentioned earlier has been to, you can conceive of all behaviors at all different levels. Right now I'm talking, but then you can get more and more specific to the point where, it's firing neurons and so on and so on. I mean, there's a certain level at which it becomes ridiculous to think of it like that. But I think what is interesting is when you scratch the surface and actually you think, you try and work out what is it that people are doing, and then you get them to talk through what they're doing, and they become aware of what they do, but that they do on autopilot. And then when you do that, you can start to see, okay, so if you're doing it in this order, how about, or actually the person themselves can start thinking, how about I take this bit out, I change that over there, I put this bit in over here, such that you've got a very fine-grained sequence. And within that sequence, exactly as you said, you can put mini habits in there. So that, for example, we did something with people who were experiencing sleep problems. And it was a case of, okay, as soon as you shut your laptop before, at the point when you'd normally go upstairs, how about you do, some mindfulness, whatever it is. But it's working out those discrete events that for that person, actually, they see as one thing. They see it as getting ready for bed, or they see it as stopping working and then getting ready for bed. But actually, if you start to break it down and think, well, what are the discrete elements of that, then you can start playing around with it more. And what's really interesting is when you do that, people themselves start to become more aware of what they're doing because they don't think of it at that level. So it's kind of, working with mini habits.
Mm. And do you think that could work at could this work at a larger scale? Is there an issue of, do you think there's a tipping point in the number of micro habits that you can actually insert into people's routines before they start getting kind of resentful?
I think it depends on how you do it. I mean, the way that we've done it so far has been working one-to-one with people to find out, and they have to be motivated in the first place. You're not going to change someone's behavior looking at their routines if it's something they don't want to do. But if they are motivated, what's nice about this process, what we call script elicitation, is when you go through it with someone and you facilitate them, they are the ones that are leading it. So you're helping them to do something that they already want to do. So I mean, there may be a point at which you or the person you're working with tinkers with it so much that actually it's completely unmanageable. They forget entirely what it was that they wanted to do. But I think it's this notion of small changes, which, everyone loves the small changes approach, but small changes at very low levels, very kind of fine-grained levels of analysis, I think is quite exciting.
I really like that. I'm while we're on the topic of habits, I'm kind of curious about the idea that actually, could habits be a barrier to behavioral maintenance? Let me explain. So I've got a habit of doing this kind of 5 p.m. I go for a walk area, but then I go on vacation for a week. Is there evidence about our habits easier to resume after interruption compared to less, things that are less habitual?
That is a really interesting question. It's one that I've been thinking of as well. I'm not aware that there is, but this is exactly how a habit should kind of operate, I think. That actually, I talked about habits being cue behavior associations. Someone, I can't remember who, it might have been Basfer Planken, wrote about how when you form a habit and you form that association, it's like, water going from a high point through the sand, and it kind of creates paths through the sand, such that when the water source finishes, those paths are still there. And when more water is poured, they go down the same thing. And so that's really interesting, this idea of habits as memory traces. They're things that we might not act on them, but when we need to reactivate them, or even when we don't want to reactivate them, they're still there. And so they should, in theory, be kind of easier to resume. And there was an interesting point made in the chat earlier about, how does habit relate to, say, wearing face masks and these kind of things that we did during the pandemic. My own theory about this would be, actually, if we do, heaven forbid, find ourselves in a similar situation with another pandemic quite soon, I think we should be able to reactivate all of those behaviors that we did before, because we still have the habits for doing them. So I think there's more to habit than meets the eye. And this is why it's important to study the habit as something different from the behavior. Because if you only look at the behavior, you see people aren't wearing face masks anymore, and you think, okay, well, they haven't got the habit anymore. That book is closed, and then you have to start again. I think there's more to it than that.
I want to jump in here real quick on this topic. There was a paper not too long ago looking at sort of co-beneficial behaviors that are both reduce carbon emissions and are sort of health promoting, looking at sort of windows of time where adopting new behaviors or sort of changing were most likely to be uptaken. And when people moved house, so when they moved to a different home, was this sort of opportunity for these new ways of setting up life. And so I imagine this is at least related, Pascal, to whether sort of implementing these new sort of things might undermine some of the old ones, or the existing habits may get in the way. I also just want to briefly, there may be something valuable in thinking about how we sort of think about addiction treatment. So people head off to a 30-day program or a however long program to sort of get out of their current context, be with other people who have similar behavior change goals, and we sort of try to instill this sort of new mindset, new, whatever. If I were given maybe 5 million, wouldn't do it. But I think one sort of big idea would be, is there a way to think about sort of a summer camp or a 30-day program or a whatever for adults who want to change their sort of health behaviors with other adults who also want to change those things? So sort of the opposite end of the spectrum from these sort of small changes. We're going to go in, okay, we're going to try to get 5 more steps in there and this, that, and the other. No, let's make a radical change and then see how much of it sticks.
That has been done. I mean, that kind of research has been done. I would argue that the radical change is going to work much better than the small changes approach. We know that the best predictor of how well a person's going to do with weight loss is how much weight they lose initially, which Bonnie Spring was talking with the other day. But Jessica Unick has studied it very carefully and shown that at 2 weeks, their weight loss can predict how they're going to do from eight years later with weight loss. So you know that initial, how aggressively someone starts off on their diet really is going to predict subsequent maintenance. But the question is why? What's happening there? Is that some kind of motivational type of thing? Or is it just that, once you get in those habits, or get those behaviors going, I don't understand. Why is it that if you put a person in a camp for 30 days and then take them out, I don't actually know that the camp analogy is such a good one, because I don't think that behavior is going to stick as well. So to think about that one more.
Any final thoughts that any final things that we should say about habits at this point? No? Okay, let's move to our next question. What have we got? if we had to summarize intervention strategies that we think that we have to hand at the moment that we think are highly effective, kind of
continued contact.
Continued
contact.
Yeah.
Social support. Trying to think of some of the ones we've already talked about today.
I'm sorry, if I could jump in here, isn't it interesting that the first two things that emerge are ones that are completely kind of anti-habit? You know, it's about, because the habit approach is very much, let's make it automatic and it will stay forever. We know that that's not the case. So in fact, the first two things that get mentioned are ones that require, you know, persisting motivation, persisting support over time.
And both social things. I think somebody in the Q&A mentioned kind of the role of social norms. I think others work on kind of actually undertaking the behavior change in community settings where there is a shared identity, kind of would seem to be impactful as well in terms of maintaining.
And on that note, and sorry, this is a delayed response to an earlier question, there's work on what's called the social cure, you know, encouraging people to not just socialize, but, you know, become part of groups, maintain their group memberships, and actually see group memberships as kind of integral to health. I mean, there are some people who define health according to not just physical and mental health, but also social health. So I think there's a great deal more to be done there to see actually just being around other people, affiliating yourself with other people, all of the stuff about social identity, what groups you see yourself as being part of. It doesn't need to be people that you necessarily, you know, see regularly or that you're in their physical presence, but you actually affiliate yourself with other people under a particular social identity banner. I think there's great scope to look at that in terms of maintenance and in terms of more generally just promoting better health.
Yes, I believe that kind of the evidence on loneliness is a greater risk factor for mortality and morbidity than smoking 15 cigarettes a day. And clearly sociality is kind of absolutely vital to our physical and kind of emotional well-being. How do you think these factors may relate to Dr. Wing's ideas about restarting, which I still think is fascinating? Do you think part of the reason why sustained contact and social support and kind of group identities or social network effects, maybe in terms of bolstering people's capacity or desire to kind of restart and not merely maintain?
I don't think those work for restarting.
There's no work, you don't think there's any work on restarting?
I don't think that they really work to allow someone to restart. I'm not sure that that's what really does, because continued contact and social support don't seem to help with long-term maintenance. In the long, I mean, they make the check mark, as someone said before, they make the check mark less severe, but they don't really remove that check mark. So I don't think you can really use that as your only strategy.
So is it useful to think about intervention strategies that are more useful for initiation or the early stages of behavior change, and other strategies that should be phased in to kind of maintain behavior change? Do you think there's a meaningful distinction between initiation and maintenance strategies? I mean, there are some strategies, presumably, that are helpful for both initiation and maintenance. Yeah, trying to make the physical activity more enjoyable, trying to promote intrinsic motivation. But are there particular strategies that we would really want to wheel out to promote maintenance?
I think if I could come in on this, I think what's interesting, again, from a habit perspective, is this idea of what's called flexible habits. And again, this goes back to what Alison Phillips was talking about with higher order habits. This notion that actually, I mean, what both of us have done work on is when we talk about, we want someone to form a physical activity habit, often what we're trying to encourage them to do is just kind of get over one decision line. If we get them to form a habit for putting the gym bag by the door, that's the thing that's going to get them to actually take the bag to work. And then once they've done that, they're more likely to do the next thing. And I think what's interesting about that is that that enables us to start thinking about making part of a sequence habitual. The decision to go to the gym, you don't have to consciously decide, you just do it. And then once you're in the gym and you're there with your gym bag, you're not really going to turn around and exit again. So what you do from that point is entirely up to you. And I think, going back to what I was saying, I think this is what's important about thinking about where habit fits in and where it shouldn't fit in. Actually, what we really want to do when it comes to maintenance is encourage people to carry on enjoying the behavior. Because you said just now, Pascal, the importance of intrinsic motivation. I think intrinsic motivation is going to be important in keeping people going as well, because they've got to enjoy it. If we just try and get someone to repeatedly do something just so they maintain it and it becomes automatic, they're not going to do it over time. Whatever it is that kind of puts them out of practice will just kind of completely finish it off because it's no longer enjoyable to them. So I think flexible habits, getting the habit of deciding to do something, but also doing it in a way that's still flexible, that gives you control, autonomy, gives you kind of some autonomy over what you're going to do and makes it enjoyable. I think that's going to be really important.
Yeah. It is a bit of the holy grail of behavior change research, isn't it? That kind of making health behaviors enjoyable. It is kind of moving things from for health purposes to actually, this is going to make you feel good. I mean, do people have thoughts about, Rena, you've run many weight loss interventions. Have you ideas about how to make the process of engaging with the intervention more enjoyable?
I don't really, because I don't know that that's such a key part of all behavior change interventions. I think it's true for exercise particularly, to make it enjoyable. I'm not sure, though, that enjoyable is really the right word for following a healthy diet. I mean, I think it's coming to like certain foods. I really do think it comes back more to that identity kind of thing, that you view yourself as a healthy eater and you view yourself as someone who's willing to try new foods. I'm not sure.
And do you think you can, in advance of kind of actually eating healthily, acquire the identity of a healthy eater?
No.
So is identity something that accrues from the behavior rather than is a cause of the behavior?
Well, I think it goes round. It goes round and around. Because that's what we saw in the registry, in this National Weight Control Registry, was that some people would start off exercising to lose weight. But then after a while, they were exercising, or they were losing weight or keeping the weight off so they could exercise better. It became sort of a, the cart before the horse or the horse before the cart changed.
Alison has just brought up a kind of very interesting question about the role of fatigue in behavioral maintenance. That people just get tired of perhaps doing something they wish they didn't have to.
Right. I do think it's a very important part. And that's why many people are now trying variety. So let's just change up the diet that you've got to follow. But I think there's got to be a timing thing to that too. It goes back to those critical moments or the right time in a person's life.
I wonder, and I mean to cut you off.
No, go ahead. I was going to stop anyway.
I wonder if there's something that we have learned or should be learning from the sort of cultural development of the notion of fat phobia the sort of, I've seen, at least in the sort of Northeast, more and more nutritionists who are really explicitly sort of don't use weight as a metric. And I think this must be sort of related in some ways to both what we've learned about BMI not being necessarily as important for, cardiovascular risk or mortality outcomes, but also I think this notion of fatigue both of the sort of societal messages around thinness, particularly for folks assigned female at birth, but also of engaging with these behaviors that may or may not give people the sort of rapid or even ever change in these metrics.
And yet you have the rise of these weight loss medications that are just so popular right now.
Yeah, interesting that both of those are happening at once.
Absolutely.
Right?
One of the big things I think is going on right now, that both of those are happening at the same time.
Can I take a question from Genevieve, who kind of says, maybe we've set the bar too high or have unreasonable expectations for how to define maintenance. Perhaps it's okay to somebody has maintained a behavior for X amount of time. What do we think? At one level, that would seem to avoid kind of possible health outcomes, but do we think that might be a fruitful approach?
Well, we do know, I mean, for example, in the smoking literature, we know that people who can stop smoking for, is it 28 days? They're far more likely to quit. And that's what's behind, here in the UK, we have what's called Stoptober. If you can just try stopping for October and, you can do whatever you want afterwards. So I think there is something behind that. I think part of the problem, it goes back to what I was saying about definitions, that hanging over all of this is, what do we actually mean by behavior maintenance? If you manage to keep up this behavior for 6 months, is that good enough? And I don't profess to know the answer to that. But then within that, what kind of degree of fluctuation can we have? If someone, as you say, if over a 5-year period, someone becomes generally more physically active, but there's the occasional month when they don't do something, are we going to treat them as a maintainer or not? So it's partly we have to get our house in order to understand what it is we're trying to target. And I think that's definitely right, that we don't want to set the bar so high that it just becomes completely unrealistic and unfeasible to achieve it.
It's exactly what I was trying to say before, because I definitely think that that's true, that we have made it so that you're maintaining your behavior is key. And that really takes away from this whole self-regulation approach, which would say that you got to keep watching your behaviors. And then if something starts to unravel, you have to do something to get back on it again. But that's very different than this maintaining forever and ever and ever, that you're never going to get off of it again. It's a different definition.
But even within the tobacco control world, which probably has kind of more formal definitions of behavioral change and behavioral maintenance than kind of maybe true of other areas, they have the idea of grace periods. And that grace periods can occur not merely at the beginning of a quit attempt, but also at kind of certain points that people may lapse. Kind of one evening they kind of smoke cigarettes, but actually, we can accommodate our concept of maintenance to the fact that occasional lapses do occur.
That Ross just mentioned in the chat that I had said the other day, which is true, that it is better to have lost more weight and have regained some for CVD risk factors than it is to have just lost less weight to begin with. So again, it would say that, maintenance may not be the end all that we have at the moment.
We should be aiming for a crash course.
Well,
so we should be aiming for a crash course of change in order to have the best chance of maintenance.
Yes.
Which is kind of interesting because I think at some levels we often think, oh, maintenance is about gradually moving people in bit by bit, and we'll get to the point of a level at which maintenance will be easier to occur. But these data suggest the reverse, that actually kind of starting with the greatest possible weight loss or the greatest possible levels of exercise.
I did a study years ago where I was trying to prevent weight regain. And what we did was we took people who've lost weight and we randomly assigned half of, or some of them, to be on a small changes approach and half of them to be on a large changes approach. The small changes approach was to just basically keep watching your weight all the time. And that if you started to gain weight, you were supposed to cut out 100 calories a day if you're eating or you exercise, add in 100 calories of exercise. The large changes approach said, no, you have to first create a 10-pound weight loss as a buffer against expected weight gain. Okay. Now, the 10-pound weight loss program worked much better than the small changes approach through at least 2 years.
Wow.
So I think that's an interesting set of data to think about.
I think there's parallel data in the smoking cessation literature where abrupt cessation is much more effective at ultimately keeping people tobacco-free than is kind of gradual reduction in nicotine intake. Can we move to the next question, please? So this question is about kind of, at one level, it kind of suggests there's a magic bullet that moves across kind of different diseases or behaviors. But when we think about different behaviors, I mean, presumably, Rena, your work is involved in both approach and avoidance behaviors, or approach and reduction behaviors. So you're trying to get people to increase their physical activity while reducing their calorie intake. I mean, have you thoughts about whether different strategies are more or less valuable for these two goals?
Well, yes and no. I mean, because with exercise, you pretty much have to do a slow changes approach. Right. You can't just take a person who's not been exercising at all, tell them tomorrow you're going to run marathons, or you're going to, do something extreme with your exercise. I think you have to have a different approach to physical activity. But certain things I think will be similar across different behaviors, like self-monitoring, goal setting, reinforcing, feedback.
And are there behavior-specific issues? Are there particular things about diet that you think that one really needs to attend to when attempting to help people change their diet as opposed to their physical activity?
I don't have a good answer to this. In answering these.
I don't think I have a good empirical answer to this, but I do have a strong gut feeling that I already alluded to, but I'll say again in a better way, and that is that if you look at people, particularly young people, but there are certainly people my age and older who are similar, who become aware of the incremental and devastating effect of every carbon emission that they themselves are responsible for. They all of a sudden become much more likely to eat plant-based versus meat-based diets. They become much less likely to fly planes to places, to use active transport, ride their bikes, or use public transportation, which reduces their sedentary time or car travel time. And I think there are at least parallels to people who eat kosher and also observe the Sabbath, so that they're not using sort of electric or other sort of things. So I think that this notion of attaching to some shared collective meaning can potentially have broad-based effects. There's only a few behaviors that we care about, right? It's like diet, exercise, medication adherence. How many other things are we really trying to get people to do? So it seems like if you can get even two of those three, you're doing pretty well.
Similar to what we used to call stealth interventions, where you're really trying to change something, but you're doing it by trying to change something else. So I had a student who used to work with me, or a faculty member who now is studying dog walking. So if you give someone a dog, you get them walking a dog, you're going to make them physically active, but you're not, you don't necessarily have to focus on the activity, you just focus on the dog.
Yeah.
And, if you get them to get a dog, it's going to have all kinds of behavior changes.
Yeah.
Called a stealth intervention.
Well, it's the side effect, the side effect of an enjoyable activity just happens to promote health, if only video games had the same effect, But I do particularly like that one. Can we try another question, please? I like Don's comment about actually our need to protest climate change would be a boon for physical activity. I think there's a lot of things we need to protest. There should be perhaps a new stealth tactic that would benefit both individuals' health and perhaps the social determinants.
There was a paper on this, an obesity researcher talking about sort of suggesting to people to get involved with activism groups, and that basically you would see people going out and doing either walks to raise money or protest or whatever. That there's a way to draft on these social movements, sort of take advantage of the things that are happening around us, as opposed to we need to build something from the ground up and get people to pay attention to us when there's so many cool things to pay attention to in the world and important things to pay attention to in the world. To sit down with us and do stuff that seems kind of boring is just hard to do.
Mm-hmm. I have a colleague in the UK that Ben knows, and he finds that apparently some ridiculous proportion of dogs are overweight, that their owners just keep giving them treats, and that there is actually the reverse effect there, where they're encouraging the owners to take the dogs for walks in order that the dog loses weight, which is particularly delightful. So our next panel discussion question is really about kind of differences in people's lived experiences. Have we thoughts about kind of, do we feel that behavioral maintenance how feasible is behavioral maintenance in an unequal world? Where there's considerable racial discrimination, where there's a good deal of poverty and lack of access. Can we strike a balance between kind of social structural change and individual or community level interventions?
I encounter this quite a bit because I work with fairly inactive communities, and to us, the hook is not physical activity or the behavior in itself. To us, the hook is the social gathering or the food offerings. So the talk on how to get a job, the talk on how to access community resources, and we connect a lot of those topics to then the health behavior that we want to promote, because we know that activity in itself is not going to motivate people to participate. So we have to be aligning our programs with what's important to the community and what's relevant to the community, and I think that that's going to be at least getting them there. And if they find, and then we have to obviously build in strategies that make it rewarding and enjoyable so that they can maintain their behavior. That's been an approach that I've learned over the years. that's worked.
So are you effectively piggybacking on community events occurring for other purposes? Exactly. And people are then more receptive because clearly the powers that be have kind of think that it's valuable that you're sharing this information with the community.
Yeah. Yeah. And we call it
health intervention.
Exactly. We know that the health behavior in itself is not enough for many people.
Mm-hmm.
You know, given the importance of physical activity and sort of the hierarchy of things that this group of people as researchers are interested in, I've been thinking a lot about the neighborhood research that has proliferated over the last 10, 15 years. And some of the research that's coming out now around ambient temperature and weather and neighborhood effects, including urban heat islands. So we know now that in the US, in cities on a very hot day, there can be 30 degrees Fahrenheit difference in the ambient temperature in two neighborhoods within the same city, which obviously has impacts for the physical activity there, but also the sleep at night. Great paper came out, Kelton Miner last year, showing that ambient temperature impacts sleep globally in terms of actigraphy, and that you already know what are the sort of moderators of that effect: low-income nations, low-income places within nations, but also just places that are hotter, which include concrete areas without tree cover and that sort of thing. So as we think about our own role as health behavior scientists, sort of taking responsibility for a geographical area and saying, okay, let's understand this area. These are the people I care about. It's similar to what Elva, I think, is doing. These are the people I care about. These people are attached to either these churches, these neighborhoods, these whatever. Is this place conducive to people being able to make these changes? And if not, what can I do to make sure that's the case? And then I can roll out some of these other sort of scientific approaches that I want to test.
Thank you. Can we go to the final slide, please, Sydney? The final one, please. Yeah. For those of us who daydream a great deal about getting grants rather than actually getting the grants, I thought this would be the ideal question. So we put it at 5 million. So there should be hopefully plenty of money for you to do what you would wish to do. But we're going to allow you kind of to write a begging letter to NIH that will allow you a kind of $1 million or 2 more if you absolutely need it. But given in a sense our session is about kind of where are the gaps, what do we need to do next? I think it's useful to ask our panelists, so what will you do next, given this delightful level of resource that NIH has given you? So, I mean, dollars are particularly valuable in the UK, Ben, kind of.
Yeah, well, if anything,
given the current state of sterling. So, have you?
I think I think I'd probably end up saving the NIH some money, because what I want to do, as I said earlier, is actually I'm really interested in speaking to people to find out about the meaning, the moment by moment influences on their behavior. And actually, this is one thing that struck me in this conversation. One thing that I think's been missing is this idea of meaning. What is the meaning? What is the value of a behavior? Not just do people intend to do it or not, but what's someone's connection with a particular behavior. So if we're talking about trying to get people to be more physically active, if this is someone who's overweight, and partly one of the reasons why they're overweight is they've avoided physical activity because they had horrific experiences of being bullied in physical education as a child, well, that's going to have a completely different meaning to them than someone who's actually had a great time and has won loads of tournaments for running and this kind of thing. So I think, I'd just be really interested in doing a study to get not so much ethnographic, but just following people around and just doing longitudinal qualitative work to just record their thoughts, their feelings, their influences at that precise moment. And we've got something like that with ecological momentary assessment, where you ask people to report on what they're doing at a particular moment, what's caused them to do it, but actually kind of doing a series of mini interviews with people surrounding particular behaviors to find out why they're doing it at that particular moment and why they're not doing something else. That would be particularly valuable for me.
Do you think people are always aware of the true causes of their behavior? I mean, since Nesbitt and Wilson, kind of, we've known that actually people respond to context without quite realizing.
Yeah, no, that's a very good point. I'm not saying that we'd get all of the information we need from asking people, why are you doing this? Because often people don't know why they're doing it. And like you said, that study, that classic study suggested that people kind of invent post hoc rationalizations to explain what they've done because they don't have insight. But I think doing that would give us more of a sense of ground level experience, ground level meaning that people assign to behaviors that we often lack.
Okay, no, that's good. Ben has left us quite a lot of the kind of 5 million to kind of for our fantasy study. So
I want to go back to something that was talked about yesterday a lot, which were these ideas of looking at individual determinants of behavior, and those individual determinants being, you know, either psychosocial or environmental, but many different types of things. And then trying to be able to identify when a person was at risk or going off their behavior. And then trying to do JEDIs or, you know, other types of approaches where you can intervene in the moment and to see if that can really change the course. I think that's a great idea. I'm pessimistic that it'll work, honestly, but I think it really deserves to be tested. And I think it should be tested in a study such as this. Right. You know, can we really identify those behaviors, the psychological, you know, other things that are going on in that person that could help us to predict what would help an individual.
Thank you. Elva, your thoughts?
So, given that I'm coming in from the org level, I've also started to delve into the business world. I've been thinking a lot about how to, and I've been working with the Promotora model to promote and implement health programs, how to streamline training so that, like, let's just say that a community health worker who is trained is, you know, life happens, no longer continues to implement the program, how to make it easy for an organization to train a new person or to keep them motivated and engaged in implementing the program. So I've been more at the sort of at the org level thinking about, well, how can we make it easy for organizations to maintain these health programs? So the business, I think the business discipline has a lot to offer in that regard. So I feel like those are opportunities for us to continue to learn.
Thank you. Don.
Thank you. I would first off use the rest of Ben's leftover money, then take Allison Phillips' idea in the chat and add to it that I'd like to randomize people to either be put in a sort of collectivist co-living situation focused around this higher order identity, higher order motivation around behavior change. Also, that situation sort of lops off some of the economic pressure. We take the economic overhead of people's lives and reduce it, and also sort of get some of this collectivist support and some shared motivation around behavior change, and see if we can make some real long-term fundamental changes.
Thank you. That's great. I'm afraid the time has come to offer people the opportunity to maintain their Friday afternoon routines. I want to thank all of our discussants, Drs. Arredondo, Edmondson, Gardner, and Wing, not only for their presentations, but also for their engaged discussion of the issues and their fast spending of $5 million. Thanks also to the audience for the many interesting and sometimes provocative questions. I'm sorry we couldn't take every question, but it's now time to hand over to the conference organizers, Drs. Connor, Center, Stirratt, and Young-Hyman. Thank you, everyone.
Thank you so much, Pascal and everyone. What a fantastic discussion. Thank you so much for your many contributions and excellent ideas. Before we close, I do want to return to Ann Peters as our co-chair. Ann, would you like to make any concluding comments for today?
Well, yes, I've learned so much listening to you all, but you all made me think of how I would use $5 million because I didn't get to answer that question. And my whole goal is to make this digital divide, or however we call it, better. And I would use the $5 million to study what I've already been doing without $5 million, which is to study how I can help improve diabetes outcomes through remote monitoring in my patients in our underserved communities. And we're already finding really high rates of acceptance and usability of these tools as long as it's done in the setting where we have connection. So we have educators and people who actually help make this happen. But there's a lot of work to be done in taking the tools that we're using in these more affluent communities and actually using it to help create behavior change. But the second thing I would do if I had $5 million is what the community wanted me to do in the beginning, is that they wanted me to create programs for their children because they wanted to help before the habits are formed. So they wanted us to run camps for the kids and teach them about nutrition, and they wanted us to improve nutrition in the schools. And I think the idea of getting behind earlier in terms of doing any of this so that we can help healthy behavior start young. And I know there's a lot of work on this, but that's what my communities wanted. So in terms of how I'd spend $5 million, it depends on which hat I have on. But I've really learned a great deal. And I believe that we're all going to try to continue this process and to try to create something meaningful with the NIH to lead us all forward, because there's a lot more that we all have to do.
Yes, and absolutely. This is, both an exciting but also vexing challenge, how we continue to work on the issue of behavioral maintenance and create effective interventions. But it's one that we're very excited to work together on with everyone who's been a part of the meeting today, both presenters, discussants, and attendees. So thank you for your interest. We're so appreciative. For next steps, we do want to mention that we will make the presenter slides available. We'll make those available to all attendees shortly, and you'll receive an email which will let you know when those slides are available for you. And they will either arrive to you through your email or on our website. So watch for that notice. And that'll be the slides not only from today, but also the slides from our session on Wednesday, which I just want to at least briefly mention one clarification, because I had misquoted Bonnie Spring's work earlier. She was looking at predictive models for weight loss and actually found that the best predictive model involved combining total weight loss in the first 2 weeks with multiple dynamic daily features of that change. And so she has several papers on the way to explain that. And sorry, Bonnie. But we will send out those slides for both the measurement seminar on Wednesday and then today's intervention webinar. And for our final step, we'll plan a fourth workshop, which is going to be held in spring of 2024. And that is on the issue of implementation, how we can take all of these good ideas and then bring them into real-world settings where individuals are receiving care and make sure that we can help people to benefit from effective interventions to support behavioral maintenance. And it was exciting to see, a lot of our discussions today start to tilt in that direction, about how we can take these forward and not just create interventions, but also think about implementing sustainable interventions in real world settings and communities. On the next slide, you'll see a a visual of the 4 workshops in this series, from conceptualization to measurement to today, interventions, and then, as we said, next spring, implementation. We mentioned this the other day, but we really see these as overlapping circles. And every time we hold one of these discussions, whether it's focused on topic A or topic B, C, or D, each discussion seems to inform all the others. So I think today we heard a lot of discussion that, although it was focused on interventions, helps us to think more about the conceptualization of behavioral maintenance, about how we can approach measurement and monitoring for it, and more. There's much work to do as we go forward, and we look forward to working on that with you together. So I think with that, we will be closing for today. Thank you for your attendance, and everyone have a very good weekend. Be well. Take care.